Hi, I'm Dr. Jeff Bland, your host for this educational program from the Personalized Lifestyle Medicine Institute. I'm really excited about this program because we're going to introduce some concepts about stress, menopause, estrogens, and the relationship to neuropsychology that I think will be very groundbreaking and have a lot of clinical importance, particularly in this day and age where we're seeing more and more women moving into the menopausal age group. So with that as an introduction, a brief introduction, let me get to the material at hand as the introduction to this topic. So let me share my screen. So mental health and menopause is the topic of choice, the role of hormone optimization. This is a first of two-part series. So this is a couple of hours of information that will set the stage in for our following 2.5 hours that we will close. So this is a 5-hour program, but what a remarkable faculty we have. Dr. Jacqueline Smeaton, an expert in the area of hormone evaluation, representing the Dutch test and precision analytic. Nayan Patel, PharmD, that is an expert from Central Drugs in really putting together compounded products for hormone modulation. And then Dr. Sarah Gottfried, whose name I think all of us are familiar with as a leader in women's health and incredible clinician and expert really in the topics that we'll be talking about over the course of the next two parts in the series. So let me jump right into the material at hand and we'll get going. So as you recall, in November 6th of 2023, there was an article in Glamour magazine. It was actually a cover article. It was entitled 1.3 million women enter menopause each year, and we have to stop ignoring them. In this article, it described the clinical challenge that many women face as they transition through perimenopause and into menopause. 1% of women go through the menopause by 40 years of age, and 5% are menopausal by 45. So it's not just a condition solely of 50 years in age and older. One of the most problematic areas of concern beyond the symptoms of night sweats and flushing are mental health related. These mental health issues are in turn related to alterations in female hormone physiology and interconnection with stress hormones. There is now strong evidence for the association between sex hormones and changes in brain function and activity in older women. And estrogen is now known to be a neurosteroid that is important in the modulation of these processes. So we're going to talk a little bit about interventions and hormonal therapies that have been found to be of critical importance in managing depressive symptoms in both perimenopause and postmenopausal women. So a big topic of importance, a lot of clinical news to use. So the schedule of events in the session one, I'm going to give a quick introduction between the connection between female adrenocortical hormones and mental health issues in perimenopause. This is just kind of setting the stage for where the news to use really resides, and that is Dr. Sarah Gottfried talking about mental health in perimenopause and menopause. Jacqueline Smeaton talking about the Dutch test, this dry urine spot test for looking at steroid hormone analysis. Dr. Patel, and then coming on to the program with hormone replacement therapy prescribing. And then a really robust panel discussion among us at the end, where we'll have a chance to have a free-form discussion of this topic. So let me, if I start with a homage for Dr. Bruce McEwen. Now, if you're not familiar with Dr. McEwen, I would say you probably are, you just didn't know it, because his impact upon our field over the last 40 years has been just nothing short of spectacular, seismic. Many people wonder why he didn't win the Nobel Prize in medicine and physiology for his discoveries. He is known as a person that kind of integrated neurology, psychiatry, psychology, immunology, and metabolism, neuroimmune function at a fundamental mechanistic level. He just unfortunately passed away a couple of years ago. I had the privilege of knowing him as a world-renowned neuroendocrinologist and the head of the Harold and Margaret Milken Hatch Laboratory at the neuroendocrinology department at Rockefeller University. And he's the one that coined the term allostasis. And in fact, it was really described in this book that he authored, The End of Stress as We Know It, which really talks about the difference between intermittent stress and allostatic load, this continued state of function where an individual is under distress, biologically, psychologically, chemically, environmentally, and the effect that it has on their overall physical, mental, cognitive, and physiological function. So Dr. McEwen published his first paper in 1959. He eventually went on to publish more than 700 peer-reviewed articles. He started off as a chemist at Oberlin College and got his PhD later at Rockefeller University in cell biology. His laboratory grew to be at the front of estrogen and glucocorticoid action in the brain. He was able to demonstrate for the first time that estrogen can increase dendritic spine density in a subfield of the hippocampus. In addition, his lab also discovered stress-induced dendritic retraction in the hippocampus subfield by pioneering the role of both gonadal and adrenal steroid actions in the brain. The McEwen laboratory helped develop the modern concept of stress. He played on what Ancelier left us with at the next level that has completely revolutionized our field. His research focused on glucocorticoid stress and neuronal degeneration. And as I mentioned to you, he is judged in part not only by the quality of the work that he did in the pioneering publications, but by also the students that he was responsible for educating. Those students included Dr. Robert Sapolsky, Elizabeth Gould, Dr. Catherine Woolley, Dr. Michael Meany, who is now, as you know, one of the great investigators in the epigenetics of stress and transgenerational inheritance factors, and Heather and Cameron, all extraordinary pioneers in their own right, that all spent time working under Dr. McEwen. So an amazing series of accomplishments. Everything I'll be speaking about and everything our clinicians will be talking about has a bearing and a relationship that derives out of Dr. McEwen's work. So I just want to pay a moment thanking him for his decades of contribution to this field, and how you will see it really making itself very obvious in the work to follow. One of his papers that was published in 2017 was entitled The Neurobiological and Systemic Effects of Chronic Stress. And he just outlined this in a simple diagram. The concept of biochemical individuality, different genes, different development, different experience that was encoded with our epigenome, and then behavioral responses to stress factors, the flight or fight, personal behaviors, diet, smoking, drinking, modifiable factors. All of these then interface with the central nervous system and create response. This is information. It's information coming into receptors that then translates those receptors into functional outcomes that lead to physiological and psychological response. Adaptation is a consequence of this constant pressure. This is the pressure of this allostatic load that he described that really defines then how a person is in a locked-in state of interaction of their lifestyle and environment and genes in terms of their expression into not only physiological and physical function, but also into psychological function, including things that we'll see like post-traumatic stress syndrome and maybe post-COVID syndrome and others. So we'll get into that in greater detail. So he came up with this allostatic load concept to really talk about the brain as a central organ of stress and adaptation. And the allostatic load is the body's attempt to adapt or to accommodate this particular exposure to environmental stressors that then become operant in that individual and distort or change the way our metabolism functions, the way our neurochemistry functions, and the way our immune system functions. The adult, as a developing brain process, it has a remarkable ability to show structural and focal functional plasticity in response to stressful events, but it doesn't mean that we're not paying a price in the process by modulating or distorting or changing the functional state of this plasticity. This intolerance in terms or imbalance affects the systemic physiology of the neuroendocrine, autonomic, immune, and metabolic systems, all of which are interrelated. So we get these complex system profiles. We get varying degrees of phenotypic expression into different degrees of symptoms of different duration, frequency, and intensity. All of that makes this field very complicated, but it's not without its checkpoints, with its opportunity to understand this complexity and to intervene. It's that which we'll be describing. So stress is mediated through these receptors in the central nervous system, through our corticotropic receptor hormone mediators, through gonadotrophic hormone release that are modified through pain receptors like beta endorphin. That influences in the gonads, in the female, luteinizing hormone, follicle stimulating hormone, which influences sex steroid hormones. All of these then are interrelated with adrenal glands as well, through release through ACTH, and then ultimately the release of the glucocorticoids at the adrenal level. So there's this interconnection between the central nervous system and the cortical system that's in our adrenal gland. So the adrenal glands, located up there on the kidneys, are those that produce stress hormones, adrenaline, cortisol, as well as testosterone and other hormones. They also have a role in controlling blood sugar levels through cortisol. They take over production of estrogen and progesterone at menopause. And I think this is a very important point to make as we get into this topic. In menstruating women, the majority of their estrogen and progesterone is produced from the ovaries. There is systemic estrogen being produced by extra ovarian sites, but it is secondary to the primary production site, which is the ovaries. Upon menopause, where ovarian estrogen secretion declines significantly, now your peripheral estrogen production and progesterone become the dominant player in that woman's body. And I think this is a very important point, because early on, you've got this double system going on in a woman's body, estrogen and progesterone coming from her ovaries and from peripheral sites. But after menopause, the majority then relies on her peripheral sites, which then relates to the overall health of those tissues that are the estrogen, progesterone producing cells that are extrauterine. And that's an important part of this transition into menopause and its effect then on the central nervous system. And it's also how it is influenced by stress, because when you have the lower reserve of estrogen producing opportunity, because your ovaries are no longer producing, now the system is more vulnerable. There are modifying factors like stress factors that can modulate then estrogen in distal sites like the nervous system. We've all seen the chicken wire diagram of the production, the so-called adrenal steroidogenesis, how the adrenal glands produce these various hormones, going down from cholesterol, pregnenolone, ultimately into progesterone, ultimately going to corticosterone, and then aldosterone, the electrolyte managing hormone. Also going through the similar pathway through pregnenolone, but then going down to 11-deoxycortisol, ultimately then into cortisol itself, this stress hormone, glucocorticoid. And then also pregnenolone can go on into DHEA, and DHEA into androstenedione, into androgens, androgens, which then get converted into estrogens through aromatase enzymes. So all of this is kind of a map, a roadmap of how different molecules go through this diagrammatic series of transformations Particularly now I'm speaking to adrenal gland steroidogenesis. This is not ovarian, this is adrenal gland potentiation. So the adrenal gland, as you know, is composed of three layers, and these layers have different molecules that they manufacture. And as those things are impinging on our body that activate those molecules, then those layers of our adrenal glands hypertrophy. So if you were under a lot of stress, then the actual layer of your adrenal gland that is associated with producing stress hormones hypertrophies, it grows larger. And so I think it's really interesting to note that this is a very functionally dynamic part of our body. So the adrenal glands responding to environmental signals, responding to inflammation, responding to stress, both psychological as well as chemical and biological and mechanical stress. All of that is being mediated then through this changing of the functional status of our adrenal glands. So in each of those regions, those layers of the adrenal glands, you have different things going on. So in the adrenal cortex, you've got these different things that are producing different molecules. Zona fasciculata is producing cortisol, and then whereas the zona reticularis is producing your steroid hormones that are the reproductive hormones that ultimately then in peripheral tissues get converted into various downstream metabolites like 5-DHT, dihydrotestosterone. So this process in the adrenal glands is dependent on the environment in which the person finds themselves, as well as their genetics, and how these different steps in the production of these final molecules, these regulatory molecules, are mediated and ultimately regulate our function. Now, what happens if your adrenal glands are the principal producers of these molecules because the ovaries have lost their estrogen creating capability? Now you're relying upon that process that's occurring in the adrenal glands, so cholesterol on into pregnenolone. But if you are under situations where you have a need for a lot of that adrenal gland to help pick up the slack in a woman's body for the production of estrogen that is being lost by ovarian decline, now you're going to be shunting a lot of that into DHEA, epiandrosterone. And that goes on ultimately into androgens and then into estrogens by this process of aromatization I talked about. And so therefore, what that does is it takes away or uses a lot of the pregnenolone DHEA into the production of these estrogenic and androgenic compounds. Now, what happens if you're under high stress? Aha, that means the region of your adrenal glands that are associated, that layer with the production of cortisol increases, the fasciculata, and in so doing then, it takes a lot of the pregnenolone that's available through metabolism and it starts utilizing it into the formation of cortisol at a decline in the amount that's available that ultimately is in the other zone of the three layers of the adrenal glands that is used for the production of androgens and estrogens. So this is called the pregnenolone steal, and that's what it's been kind of euphemistically labeled. And that then has an impact on fertility. That has an impact upon estrogen modulated and mediated and progesterone mediated effects in the central nervous system. And it then is the kind of basic molecular biology, cell biochemistry that connects together stress with estrogen effects on the nervous system. So it's a very interesting kind of example of how understanding fundamental cellular biochemistry can translate into our better ability to understand clinical pictures that have these complex profiles downstream, such as the peri-menopause and menopausal symptoms. So if we looked at the connection between the hypothalamus pituitary adrenal axis with that of the gonadal axis, the hypothalamus pituitary gonadal axis, there is an interconnection, obviously, between the two, gonadal hormones and the stress hormones in the adrenal glands. And you'll notice that there is this series of red lines that connect cortisol together with the metabolic pathways that are associated with the production of estrogen and progesterone, in that the cortisol, when it's increased during periods of stress, has adverse impact upon gonadotrophic releasing hormone, ultimately inhibiting LH and FSH production. That changes in androgen and estrogen production at the ovarian, at the systemic level. And so now what we do is we start suppressing the androgen estrogen activity through the overactivity of stress that is then activating the HPA at the expense of the HPG axis. So this is a very, very important part of our clinical story that we'll be talking about in women who have compromised their integrity, their HPG axis, as a consequence of overactivity of the HPA axis. So a recent paper that really described a lot of these interwovings between neurobiology and metabolism and the psychology of female was this extraordinary paper that I found to be filled with insight on the stress of being a woman, the synergistic contribution of sex as a biological variable and gender as a psychosocial one to risk of stress-related disorders. Let me say that title again. That's a real mouthful, isn't it? On the stress of being a woman, the synergistic contribution of sex as a biological variable and gender as a psychosocial variable to the risk of stress-related disorders. We're living in this very complex time where we're better understanding the interwoven between sex as a biological function and gender as a psychosocial function, and how they interact in our environment to produce then outcomes that are related to various behaviors and affects that are associated with stress-related disorders. Now, how does that translate? So in this article, they say stress-related disorders disproportionately affect women. Cortisol blunting, a failure to demonstrate a typical rise and fall of cortisol in response to stress, is associated with the stress-related disorders that are seen in women, and it's been found to be more profound in women. Cortisol blunting relates to both sex as a biological variable, important, estrogens and their fluctuations and the impact on neural circuits, and gender as a psychosocial variable, discrimination, harassment, gender roles. So now we've coupled these together. This author suggested a model linking experience, sex, and gender-related factors and neuroendocrine substrates of stress-related disorders is heightened risk among women as a consequence of these interrelationships. A very, very powerful concept that you're going to be hearing more from our other presenters. So if we were to model this, then we're talking about the HPG axis connected again to the HPA axis, and how stress then modulates through this sequence of events, ultimately epinephrine and cortisol influence on sex steroid hormones that ultimately changes then the neurobiology of the brain and produces affective changes in the individual's outcome and outlook. That goes through a couple of components of the brain function, hippocampal function, amygdala function, and it is a really important part, I think, of this brain neurochemistry and its interrelationship with our environment, our lifestyle, and our genes. So here we go. In summary, gender roles and past experience coupled together as general stress, coupled with I guess you call it occasional stress. It comes from stressful psychological events, trauma, infection. Those all then relate to this kind of complex aggregate of stress-related disorders that then modulates through these functional changes in the cortical arousal system, estrogen effects on target tissues. And now we get this complex symptom profile, things like dysphoria, depression, sleep disturbance, cognitive dysfunction, and so forth, forgetfulness, foggy brain syndrome, many complex outcomes from this constellation of factors. So what about estradiol therapy, E2, after menopause? Does it mitigate some of these effects of stress and cortisol and working memory? This is a paper published a few years ago that looked at evidence showing that estradiol can protect certain types of cognition in the presence of stress. Estrogenic protection against stress hormone exposure may prove beneficial to both cognition and neural circuitry, goes on to say in this article. So this gonadal response to social stress and responsibility and relationship to ultimate neurochemistry and estrogen metabolism, I think, is very important. As I stress it here, these gonadal stress responses appear to be largely independent of cortisol response. These results demonstrate that endocrinological stress response is not restricted just to the HPA axis and stress responsivity of the gonadal hormones, but it's also related to other factors beyond that of cortisol itself that modulate through the psychosocial variables the neurochemistry that regulates mood, mind, memory, and behavior. So it's a complex milieu. There's not just one path to enlightenment here, but certainly the HPA axis in connection with the HPG axis play very important roles in modulating these downstream effects. Now, what do we know, therefore, about stressful effects and their influence on hormone levels? So here are some recent data looking at men in the dark squares and women in the red squares as to the role that continued stress, allostatic load, to use Dr. Bruce McEwen's nomenclature, has on things like estradiol, testosterone, and as cortisol then goes up, you start seeing the steroid hormones going down, and women have this dramatic reduction in the outcome or output of these hormones under constant stress. As I mentioned, estradiol levels modulate brain activity. It's a neurohormone. It provides a buffering against psychosocial stress across the menstrual cycle. This was an article published in 2015 looking at the study suggesting normally cycling premenopausal women that high estradiol levels attenuate the brain activation changes and negative mood response to psychosocial stress. So again, weaving in the important role that estrogens play in this neurobiology and as neuroactive hormones. So if I was to kind of summarize this introduction, what I would say is that we now recognize that estrogens are more than just reproductive active hormones. They are neuroactive steroids that have very important roles to play in modulating mood, mind, memory, and behavior. Estrogens are modified by stress that's mediated through the adrenal cortical system. This is showing the interconnection between the HPA system and the HPG system and how they crosstalk and modulate then the functional changes in the individual. I've gone on to introduce once again the fantastic and important clinical concept of Bruce McEwen allostatic load, where a person is into a set point of response to stress, where their body has learned over time how to manage that by modulating its functions, but not at some expense in terms of clinical symptoms, in terms of optimal function. So allostatic load describes the interaction of stress on the neurobiological, endocrine, immune, metabolic, functional level in women. And this concept of allostatic load and diminishing it or reducing it is a very important clinical objective through the introduction of personalized lifestyle medicine intervention. We want to lower the allostatic load, allow the native resilience of that woman to increase. And if you think about it from kind of a visual perspective on the adrenal glands, we want those layers in the adrenal cortex to reestablish their proper set points so that they can modulate arousal, they can modulate reproductive function, they can modulate the formation of these neuroactive compounds so that we have higher resilience, higher organ reserve, so to speak, by finding the lowering of the allostatic load. The interaction of adrenal functional reserve with estrogen-mediated functions has a long-term impact on stress response in women. So it's a push-pull, two-way street argument. Stress induces alteration in the HPG axis, but the HPG axis influences also the stress response through the HPA axis. So finding ways to normalize the function as a system, HPA, HPG system, a joint system, is extraordinarily important in intervention. And what we have really said is menopause depletes estrogen and increases stress response. And its impact, then, therefore, on neuroimmune function is enhanced. So you start seeing more dysphoria, depression, and things of this nature clinically presenting itself. So what we're going to learn clinically is how to raise extra-ovarian estrogen activity and receptivity so that we can minimize the adverse effects of lowered estrogen because of estrogen loss in menopause, and we can enhance then the function of the peripheral estrogen production so that it is capable of providing this reserve that's necessary for functions beyond that of reproduction. Well, I hope this is a good introduction to what you're going to hear in much more detail from our clinicians in both of how to assess and how to intervene. Remember, this is a two-part series, so we have two shots on goal here. But I thank you very much for your willingness and participation in this this introduction. With that, I think we're ready to move back into the body at large. So now we'll move into our first clinical expert and have an opportunity to really look at how this translates into clinical news to use. Thanks so much, and stay with us. Don't forget about our panel discussion at the end.
Hi, everyone. It's Dr. Sarah Gottfried. I'm so delighted to be with you today to be talking about mental health and perimenopausal menopause. I feel like this is a topic that gets short shrift. We need to pay a lot of attention, especially to the female brain in transition. It sets us up for vulnerabilities that men often don't have, as we will get into during this talk, as well as next week's talk. So I want to start first just by thanking Dr. Jeff Bland. He's been an inspiration to me for many decades, as I know he has been for so many people, maybe you. And I want to thank Dr. Jacqueline Smeaton for inviting me to be here today, and to Nicole Fox for organizing all of this. We're going to talk about the hormonal changes that women experience with aging as modulated by estrogen, progesterone, and testosterone, with the focus on perimenopause and menopause. And in precision medicine, I like to think in terms of phenotypes. So we're going to focus on the mental health phenotypes and some of the differences in risk that women experience compared to men. And I say that because so much of the research is divided into those that are assigned female at birth and those that are assigned male at birth. And I want to acknowledge that I want my language to be more inclusive. And this idea that gender is binary is really an outdated notion. We're also going to talk about the risks and benefits of hormone therapy for mental health based on the latest evidence, including our understanding of the critical window hypothesis. And I believe for the female brain, the critical window might be a little bit shorter than it is for cardiovascular disease. Overview. Women go through these sweeping hormonal transitions. And as an engineer, when I look at the transition that women experience starting around age 35 and going on to about age 45, the change in the amount of estrogen that is coursing through the body is dramatic. The change in the slope is really severe. And this is illustrated compared to what happens with testosterone in men. We just know that the transition that men experience with hormones is much more gradual. And so it's the steepness of that transition, of the slope, that triggers so many symptoms for women: mental health, physical health, maybe even spiritual health. On the right, you can see some of the symptoms of menopause as a function of time. And on the bottom, estrogen levels as they transition, for women who are sensitive, that can be around age 43, onto the date of their last menstrual period, or when they have a hysterectomy or some other reason that they're no longer cycling, which on average is age 51 in the United States. And I want to highlight how the symptoms of perimenopause and menopause change as women get older, and some of the conditions that they face. And often it starts 35 to 40 with fibroids, weight gain, breast soreness, irritability, nausea, and then it can transition into mood swings, loss of libido, hot flashes, insomnia, night sweats, irregular periods, and then can continue toward depression, heart disease. And part of the point I want to make is that while there's more than 100 symptoms associated with perimenopause and menopause, the mental health symptoms, so many of these symptoms that we're describing, like the mood swings, the loss of libido, the insomnia, all of these are in some ways interdependent, and they really reflect a control system, which I think of as the hypothalamic, pituitary, adrenal, thyroid, gonadal, gut axis, a control system that becomes wonky, it becomes dysregulated. And at the center of that is the female brain. So even though women may come and talk about their hot flashes and night sweats, and you want to see if they're a good candidate for hormone therapy and consider treating them for that, we want to be thinking about the control system. We want to be thinking upstream of what could be driving some of these mental health concerns that women have. Is it related to low progesterone and poor sleep? Is it related to blood sugar dysregulation and the change that occurs in terms of immunometabolism as women get older? So we want to be thinking from a root cause perspective and performing root cause analysis. While we're talking about mental health today, I think it's really critical that we realize that cardiometabolic disease is really the key killer of both men and women. So 9 out of 10 of the top killers are related to cardiometabolic function. And so I just want to highlight, before we get into the details of mental health, that at equal age, women have more cardiovascular risk factors than men. In fact, 1 in 5 women die from cardiovascular disease. And this is an order of magnitude higher than the number of women that die from breast cancer. So even though women are so concerned about breast cancer, and they've got good reason to be concerned about breast cancer, it's important to realize that it's cardiovascular disease that's really our killer. And often what's good for the cardiovascular system is also good for the brain. So we know that cardiovascular disease is the #1 cause of death for Black and Caucasian women. And even though you might have heard some good news about the reduction in cardiovascular disease mortality in the United States, we know that hospital admission with acute myocardial infarction is on the rise in women who are younger, 35 to 54. So in this course, we're going to be talking about perimenopause, menopause, and I would put these women squarely in that category. So this idea that you might have that women have to get through menopause before they catch up to men in terms of cardiovascular disease is really wrong. We need to be thinking about risk profiles much earlier. And some of the same risks that are at the root of cardiovascular disease or cardiometabolic disease, such as insulin resistance, inflammation, a lot of those things are also associated with a greater risk of mental health complaints. So we want to be thinking about the interdependence of these networks. There's some gender differences, not just sex differences, which are biological, but gender differences, which are socially constructed. And that includes the fact that women experience a 10 to 25% lower chance of early medical care when they have cardiovascular disease, especially acute myocardial infarction. And in the United States, one woman dies every second from cardiovascular disease, every second. So just as I'm talking, we've had another, I don't know, 500 women die. We need to be figuring out how to solve this. So a few statistics that I think are helpful when it comes to mental health in perimenopause and menopause. We know that about 80% of women experience psychological or physical symptoms, and often they travel together. When it comes to mood, we know that women are more vulnerable than men. The lifetime risk is about twofold higher in women compared to men. And this is seen not just in the United States, but globally. What gets a little confusing is that when you look at perimenopause and menopause, the odds of major depressive disorder is not increased in perimenopause compared to premenopause, but there are more depressive symptoms in perimenopause, but not compared to postmenopause. So there's a few distinctions that I think are important to track. We also know that symptom severity of depression in perimenopause is higher compared to premenopause. And I'll give you the punchline here. I really believe that women who have depressive symptoms or who meet criteria for major depressive disorder should be treated as a first line with bioidentical hormone therapy, including transdermal estrogen and oral progesterone, assuming they have a uterus. And I think this should be done before selective serotonin reuptake inhibitors. Those could certainly be added at the same time or added sequentially, but I disagree with most of the guideline groups and really believe that because hormone therapy can be so effective, because the root cause of depression in perimenopause and menopause often is hormonal, that women deserve a trial if they're good candidates. We also know that vasomotor symptoms, hot flashes, and night sweats increase the risk of depression by about 2x. Symptoms of depression are often dismissed in perimenopause because it's attributed to the transition. Oh, you're just getting older. Oh, you're just going through perimenopause. Why don't you exercise more? No, we need to help these women. We need to take their concerns really seriously, and we need to offer them evidence-based solutions. We also know that sleep disorders are increasingly common in perimenopause and menopause, and similar to depression, we know that insomnia is about twofold higher in women compared to men. And so that always makes me think, okay, what's going on with the control system? Is the same dysregulation that leads to a greater risk of depression also leading to this greater risk of insomnia? Are they intertwined? Are they interdependent? So what do we know about some of the sleep disorders that we see? It's a critical part of this bidirectional relationship that occurs between the sleep-wake cycle and your production of sex hormones and gonadotropins. We know that menopause and perimenopause related sleep disturbances can affect so many different things. It can affect your cortisol the next day, your insulin. It can influence your eating behaviors, the timing of when you eat. It directly affects your immunometabolism, and it can certainly affect abdominal adiposity. Menopause is associated with a greater risk of sleep apnea. We should be screening our patients for it. And another important point that I want you to understand is that vasomotor symptoms, hot flashes, night sweats, while they increase the risk of depression, I also want you to understand that they are a biomarker of something more serious occurring below the hood. So we know that untreated, that vasomotor symptoms can indicate cardiovascular risk, increased cardiovascular risk, including an adverse cardiovascular disease risk profile, greater subclinical cardiovascular disease, and even cardiovascular disease events. So some newer data suggests that untreated vasomotor instability can actually affect the endothelium. It can impair endothelial function, which puts women at a greater risk of hypertension. It also is associated with a greater risk of osteoporotic fracture, cardiovascular disease, as I mentioned, depression, as I mentioned, and cognitive impairment. So when you ask women what they're most worried about as they get older, they typically say breast cancer and Alzheimer's disease. And so when we talk about mental health and perimenopause and menopause, we need to be talking about these other factors as well, including how cognitive changes can start to occur after the age of 40. Now, the sad part is that many of these women are going to their gynecologists, and only about 2/3 of gynecologists are screening these women for depression. So there's a third of the gynecologists out there who are not screening their patients for depression. So we really need to be thinking about this gap that occurs in terms of perimenopausal and menopausal care and how we can close that gap. How can we get directly to the consumer? How can we offer services that provide what these women most need? So I've got citations for all of these on the next slide. So let's talk about menopausal symptoms. We know, as I mentioned before, that about 80% of women experience symptoms. And the range can be from early in perimenopause to late. We know that the earlier they occur, the longer the duration. And this maps to a number of other conditions, including sleep disturbance, depressed mood, decrements in physical, social, and emotional quality of life. And so we have to think of this as a web of all of these interdependent factors. So I'm not going to talk about depression and isolation. I'm not going to talk about anxiety and isolation. We're going to talk about how all of these different dysregulating factors conspire against a woman feeling her best over the age of 40. We know that there's certain risk factors that put women at a greater risk for vasomotor symptoms, and that includes her body mass index, smoking, depression symptoms, alcohol, and race. The longest duration of vasomotor symptoms is in Black women, and then Latinx women. The shortest duration is in Chinese and Japanese women. So we talked about how vasomotor symptoms can be a biomarker and indicator of cardiovascular disease. And I think it's important to know for your patients who are still having vasomotor symptoms as they get older, so later menopause, that is associated with a greater risk of cardiovascular disease. It's an atypical risk factor. Another factor that's important when we think about the female brain and transition is that vasomotor symptoms are associated with white matter hyperintensities. And so you can see this on T2 weighted MRI scans. It's thought to be related to small vessel disease. And it's also associated with some of the traditional cardiovascular disease risk factors like hypertension, insulin resistance, autonomic dysfunction, stroke, cognitive decline, dementia, and mortality. So in midlife women who have no clinical cardiovascular or cerebrovascular disease, vasomotor symptoms are associated with a greater white matter hyperintensity burden. So we want to be thinking about this and also about the role of sleep and how that can be associated with poor sleep can be associated with brain small vessel disease at midlife. So this is all to set us up and start thinking about some of the ways that we are approaching and treating women at midlife, especially with regard to their mental health. So the SWAN study was the study of women's health across the nation. There's been a number of publications that have come out of SWAN. But one of the things that I was curious about was whether women experience more perceived stress during the perimenopausal and menopausal transition, and also if it varies by race, by social determinants of health. So in this study, total of 3,000 subjects, it was multiracial with about 47% white folks, 29% Black, 17% Asian, 7% Latinx. They found that high perceived stress at baseline was found in women who are Latinx, women with less education, and women with financial hardship. They found that the change in menopausal status did not predict perceived stress. So if you have this vision of women going through perimenopause and menopause and having more perceived stress, that's not been borne out by the literature. So when it comes to mood disorders in women, let's pull out a little bit from just looking at perimenopause, menopause. We know that with these large hormonal changes that women experience over their life cycle, that they're more likely to experience mood disturbances, anxiety, depression, especially at puberty, menopause, when they're perimenstrual, like the week before their period, and also when they're postpartum. I also recently looked at the bipolar data. We know that bipolar symptoms largely increase in menopause, and this is based on a study of a meta-analysis of 9 studies, overall small in size, 273 participants. And they found increased depression in women diagnosed with bipolar disorder at the time of transition. They can also have their first onset of bipolar during perimenopause or menopause. Now, importantly, and I'll repeat this a few times, there are a number of small randomized controlled trials showing that estrogen therapy is effective in improving clinical depression in perimenopause, but not post-menopause. So you've got a citation for this. This has been shown over and over again. So there's not large randomized trials, but the small randomized trials that we do have show that when you're in that time of hormonal flux, and that's typically, 8 to 10 years before your final menstrual period, that's when treating depression with estrogen therapy seems to be the most effective. There's a lot more work looking at testosterone in men, and we know that in men, testosterone seems to have protective benefits against anxiety and depression, but that's not been shown in women. So in women who have been treated with testosterone therapy, the evidence is really mixed. So it might be that there's certain phenotypes of women who do better with estrogen, progesterone, probably in perimenopause, maybe with the addition of testosterone, but we're still not totally clear on which phenotypes are the ones that are most important to treat. So getting back to sleep, I just want to highlight the interdependence of all of these different networks in the body. So we've got sleep as one of the factors that is upstream from the immunometabolic dysfunction that we see so commonly in perimenopause and menopause, and is often at the root of mental health concerns. And I just want to highlight that there's so many other factors that we want to consider. We talked about stress, social and environmental determinants of health. There's age and genetics, and I practice precision medicine, so I love to talk about, the gene environment interface. There's lifestyle factors, the way that you're eating, the way that you're moving, the way that you're connecting and loving others, whether you're smoking, whether you're drinking too much. There's sympathetic activation, there's nutrient energy stress, and then there's your hormones. So the hormones are important, sleep is important, but it's not the whole story. When you put all of these things together, probably some other factors too that are not listed here, that can lead to immunometabolic dysfunction. And that can then decrease health span. So, for my patients, one of the first things I ask when I do an intake is what they want their health for. what's the purpose of your health? I get various answers. Some people say they want to see how their kids turn out. They want to go to their grandchildren's or great-grandchildren's wedding. So we all have different reasons for health span, that period of time that you feel fantastic and relatively free of disease. But these factors can conspire against having the kind of health span that you may want. And that can lead to age-related disease, including cardiovascular disease, cancer, diabetes, frailty, and sarcopenia. And it can also lead to disability, both physical and cognitive. And I'd put, we think the leading cause of disability in the next few decades is going to be depression. And so I'd put mental health factors here too. So estrogen is really the primary regulator in those that are assigned female at birth. And I want to just highlight a few factors related to this. First, it's important to realize that the female brain starts to have this estrogen imbalance, typically starts over the age of 40. It can kind of reach a peak around age 43. It just depends on other factors. But this estrogen imbalance can affect mood and cognition. So it definitely has a map to mental health. And as we think about this, you can see this illustration down below. When you have kind of balanced estrogen levels and balanced neurotransmitter signaling, this leads to a state of healthy memory, good verbal memory, and we'll circle back to this in a moment, recovery of working memory, a lower risk of dementia, and also healthy libido. I really feel like the female body is especially well designed to be an instrument of pleasure. Not all women activate that particular pathway, but I think it's really critical. It's part of tend and befriend. It's part of some of these virtuous pathways, biochemical pathways that are in the female body. And what happens to some of us is that there are these imbalanced estrogen levels. So dysestrogenism, exposure to xenoestrogens, leading to abnormal balance. What does that do? It can lead to a greater risk of neurodegeneration. It can lead to, once again, a 2x risk of Alzheimer's disease in women compared to men. It can lead to a greater risk of depression, decreased libido, increased irritability, and also just deterioration of mood swings, and irritability. So that's kind of the concept with estrogen as the primary regulator. And then as we talk about estrogen, really we're talking about a whole family of different molecules. Most of the research that we have is looking at estradiol, especially when it comes to mental health and mood. So estradiol is what is produced primarily by the ovaries and adrenals. It's what we believe is cardioprotective, at least up until a certain age, somewhere around 55 to 60. And it also contributes to gynecologic issues. Estrone is produced in the periphery by aromatization, and it doesn't decline to the same degree that estradiol does. And then there's also estriol, which is the primary type of estrogen that's produced during pregnancy. So those are three types of estrogen that we want to be thinking about. And then, of course, there's metabolites. So I want to spend a moment talking about guidelines and talking about what conventional organizations are saying about hormone therapy, especially when it comes to mood. So I'll start more generally. This is from the 2022 position statement of the North American Menopause Society. These are FDA-approved indications for hormone therapy. So their purview, their list of indications is pretty narrow. And that includes first-line therapy for relief of vasomotor symptoms in appropriate candidates. So that puts the onus on clinicians to determine if the person in front of you who's suffering from depression or anxiety or some other symptom related to perimenopause or menopause, whether they're a good candidate for hormone therapy. It's also FDA approved for the prevention of bone loss, not the treatment. so to prevent bone loss. It's also FDA approved for women with hypogonadism, primary ovarian insufficiency, or premature surgical menopause without contraindication. And it's recommended that that be given until the average age of menopause, which, as I said, is 51. I think women should be treated longer than that, but that's another conversation. And then they also speak to low-dose estrogen therapy as a first-line treatment for genitourinary syndrome of menopause, but that's less of a mental health issue, so I'm not going to talk too much about that. But when it comes to mood, let's see what the North American Menopause Society says. They say there's insufficient evidence to support hormone therapy use in the treatment of clinical depression. They do, however, say in small randomized trials, estrogen therapy was effective in improving clinical depression in perimenopausal but not post-menopausal women. So I agree with that assessment. The data are mixed in menopausal women. In perimenopausal women, does seem to be beneficial to give estrogen therapy, and that's what I use as a first-line agent, along with a functional medicine approach to dealing with depression. They make the point that progestogens may contribute to mood disturbance. And as you may recall, the way we think about the progesterone side of the equation with estrogen and progesterone is that natural progesterone, which we give as micronized progesterone, is bioidentically the same as the progesterone that the female body has made, men make it too. And progestins are a synthetic version. That includes drugs such as medroxyprogesterone acetate, norethindrone acetate, and that's, the medroxyprogesterone acetate is what was studied in the Women's Health Initiative. Progestogens are the combination of the two, progesterone plus progestins. So we know that it's primarily the progestins that could contribute to mood disturbance. We also know that women who find that their depression improves, say you're treating someone in perimenopause with major depressive disorder or with depressive symptoms, and our symptoms improve, when you then remove the estrogen therapy, often their mood worsens. So that's kind of a corollary that you might expect. So here's what I do when I'm assessing a woman in perimenopause and menopause, and I'm trying to determine if she's a good candidate. I do more extensive testing than a lot of other folks, just in my role working primarily with executives and professional athletes. But I do healthcare maintenance, or I make sure that they have it, a full exam, pap smear, HPV, mammogram, colonoscopy, whatever basic primary care they're entitled to. And then in the serum, I do cardiometabolic risk profiling. I also do extensive hormone testing, and you're going to hear more about that from Dr. Smeaton. I do bone turnover markers just to see where someone is. I do coronary artery calcium scans in my patients at age 45, both men and women. I do dried urine testing for looking at the hypothalamic pituitary adrenal axis and metabolomics. I do salivary cortisol for cortisol awakening response and the diurnal pattern. And then more optionally, you can use your discretion. I also do genomics to pair together with biomarker testing. I do nutritional testing to look at micronutrients and also heavy metals. I use a lot of wearables, things like rings, continuous glucose monitoring. I look at heart rate variability, especially through the perimenopausal transition. I find that wearables and looking at sleep and doing N-of-1 experiments, that can be really helpful. I do stool testing. I also sometimes look at intestinal permeability, organic acids, DEXA scanning, and CIM2, carotid intimal medial thickness as a measurement of subclinical atherosclerosis. So here are the indications for hormone therapy. Number one, vasomotor symptoms, just as recommended by the 2022 NAMS consensus. I think mood is an indication. I think anxiety is an indication. I think sexual dysfunction is an indication. I think early subjective cognitive decline is an indication. The FDA says vasomotor symptoms and the prevention of osteoporosis are the only FDA-approved indications. My indications are broader, and I certainly use it to lengthen health span. So there's a lot of things that modulate estrogen levels. We think of, the production from the ovaries and from the adrenals as the primary thing that manages levels. But when you go through the Institute for Functional Medicine, thank you again, Dr. Jeff Bland, for being the father of functional medicine, we know that there's this mnemonic for looking at estrogen levels. It's PTSD, kind of an unfortunate mnemonic, but it stands for production, transport, sensitivity, and detoxification. And so we want to be thinking about, some of these network effects in the background, and how the role of aromatase, the role of sex hormone binding globulin, the role of estrogen receptors and xenoestrogens, endocrine disruptors, the role of detoxification, how all of those things can conspire to affect estradiol levels and then downstream lead to changes in terms of mental health. I was recently on Andrea Nakayama's 15-minute matrix, and we talked about estrogen regulation in women. So I just wanted to show you a matrix that I made for her, looking at things like antecedents, some of the SNPs that are involved in estrogen regulation, triggering events, including things like antibiotics, alcohol, fiber, mediators, things like hormonal contraceptives, and then here's the center of the matrix. And then, of course, lifestyle factors on the right. So I'm not going to go through all of this. I just wanted to mention that if you want to hear more about estrogen regulation, listening to her podcast is highly recommended. So let's get to safe and responsible symptom management. I just want to say a few things about this. First, I practice integrative medicine along with functional medicine and precision medicine, all the medicines, root cause medicine, personalized lifestyle medicine. And when I've got patients with vasomotor symptoms and I'm trying to help them maybe prevent that path that they might be on toward the development of depression or anxiety, I often start with paced respiration. I also think that mindfulness-based contemplative practice can be really powerful. Things like meditation, Tai Chi, mindfulness-based stress reduction, all of those have been shown to reduce vasomotor symptoms, improve mood, and improve sleep. We also know that acupuncture is very effective. And then keep in mind that when you're considering whether someone is a candidate for bioidentical hormone therapy, it's not just a yes/no question. It's also a what dose and how long. And even low dose, like 0.025 milligram estrogen patches, estradiol patches, can be very effective. So the way that I address it safely is usually to start with vasomotor symptoms, paced respiration. I talk about this in my book, The Hormone Cure. I also use a lot of Siberian rhubarb. I do genotyping. I assess HPA activity with the Dutch or with saliva testing or both. I do cardiometabolic phenotyping. I also do breast cancer phenotyping. I look at bone density. I look at whether a woman needs local therapy for genitourinary syndrome of menopause. And then I talk about the risks, benefits, and alternatives of hormone therapy. I also give full informed consent before I start a patient on hormone therapy. I think that's really critical. So with that, I want to thank you for your attention. It's been a delight to be with you, and I hope you really enjoy this conference.
Hi, everyone. I'm Dr. Jacqueline Smeaton. I'm a naturopathic physician and chief medical officer for Precision Analytical, makers of the Dutch test. And I'm really excited to be a part of this seminar and really be able to share with you a little bit more about the Dutch test. Now, today, we're going to be talking about sex steroid hormone assessment and menopausal symptoms. This is one of the main reasons that people utilize Dutch testing, is to support patients both before they go on hormone therapy and for monitoring of hormone therapy. So I'm going to share a little bit about that with you in the next half an hour. First of all, I want to address that big question: is testing beneficial for hormone prescribing? Now, menopausal associations don't recommend HRT monitoring or testing as standard of care. So I think the first question we have to ask is, why could it be beneficial? And why do they make that recommendation? First of all, most other hormones are recommended to be monitored. Of course, thyroid hormone is an example, even testosterone in males. Testosterone replacement therapy, the standard recommendation is to be monitoring. But why for females do we not recommend monitoring for hormone replacement? This really, I think, comes down to three main reasons when we think about it. First is that most of the time when they're talking about monitoring, serum is not a great monitoring tool to monitor estrogen and progesterone therapies. There's a couple of reasons for this. One is the pharmacokinetics for oral and topical therapies make it very difficult to monitor how much hormone exposure a patient might have from therapy. The second is that serum, as you know, is just a single spot check. It's only a single point in time. It doesn't represent the total area under the curve that you would see with that pharmacokinetic change when you ingest a medication. So again, it's very difficult, especially based upon patients' biochemical individuality, to know what time post therapy you would test, 12 hours, 24 hours, et cetera, and then what that means. And really what we see is that 24 hours after therapy, even 12 hours after therapy, the levels are quite low compared to where they go before that initially. The next is that there's a great safety profile for HRT. I'm not going to talk much about this today, but there's very low incidence of side effects or risks, particularly if you're using transdermal estrogen paired with oral progesterone. And lastly, most of these are being used for symptom relief of vasomotor symptoms. So the patient should be able to feel a response. Couple pieces of caveat to that. First is that there's a really high placebo response with hormone replacement therapies with estrogen and to treat hot flashes. So even really low doses of therapy, patients might report relief from, because there is a very high placebo response. And second, there are, as we know today, benefits that go beyond resolution of vulvovaginal atrophy or vasomotor symptoms, things like protection of bone, cardiovascular protection, potentially some cognitive benefits. So in this case, getting the dose right really does matter, and you really wouldn't see or be able to determine if those goals were being met if you're basing it only on a patient's vasomotor symptoms. So what are some good ideas for baseline assessment for patients that are going on to or that are considering hormonal replacement therapy? I think menopause is such a great time to check in across all areas of health. So I like to do a complete assessment, lipid profile, comprehensive metabolic panel, looking at thyroid function, high sensitivity C-reactive protein, looking at metabolic function, maybe looking at hemoglobin A1C, fasting insulin. Of course, you'll catch fasting glucose in that comprehensive metabolic panel. Looking at a patient's CBC and ferritin levels. You could check in on FSH. It's not necessary, but you could see, is this really elevated? Are they still, having the fluctuations in FSH, or are they truly postmenopausal? I think it's also great to look at vitamin D. I still find so many patients, even if they're taking vitamin D, are low. They're not taking enough. And then you would look at hormone levels, free and total testosterone, maybe dihydrotestosterone, estradiol, or looking at a broader panel of that, measuring cortisol and DHEA sulfate. And then lastly, we're going to talk a lot about urine hormone metabolites. So this is the hormone page of the Dutch Complete and the Dutch Plus, the main Dutch tests that we run. And I really love this when we're looking at postmenopausal females, because it really tells you a lot, both about production, but also metabolism of various hormones. So just to orient you to the page here, on the upper right, you have progesterone. Down below that, you have all of your estrogens and estrogen detoxification. And then to the left and right, you have androgens. This is a female report. The male reports look different. We're talking about females today. So a couple things that you can see here. One is you can see progesterone, and we give a weighted average of the metabolites here to suggest a serum relevant range. You can see the metabolites here. One thing that's interesting with progesterone metabolites, you'll hear later that we don't recommend monitoring progesterone with the Dutch test. But you can really gain some information here depending upon the type of metabolites that patients prefer to make. In this case, it's low, so it's looking low for both, but this patient slightly favors alpha-pregnadiol. You can see another example here that we've put in where they would strongly favor alpha-pregnadiol. And the nice thing about that is that that metabolite has a stronger preference for GABA receptors. And so patients are more likely to get that relaxation and sleep support that many report when they take progesterone. If they had a strong beta preference, you might not see that same benefit. And here's an example of that down here. Next, we can look at estrogens and estrogen metabolites. Now, you can see the main estrogens here, estrone, estradiol, and estriol. It does measure the levels of hormones there. But then the area that's really unique is looking at bioelimination. So towards the right, this section here, you can see production of 3 metabolites of estrone, 16-hydroxy, 4-hydroxy, and 2-hydroxyestrone. We've tried to kind of color code these to give you a little bit of a hint as to what you would want to see, but generally you want to see metabolites of estrogens going down that 2-hydroxy pathway. We show it with estrone, but this is relevant with estradiol and estriol as well. So you'd really want to see a preference for 2-OH. This is really what we consider the preferred pathway, the safest pathway for bioelimination. The next that you would want to look at is the 4-OH pathway. This is the least preferable. And the reason for this is that it's really reactive as an intermediate state. It can form these reactive quinones. And if those are not detoxified by glutathione, they can actually bind to DNA and cause damage to DNA. So we want to see less 4-OH. And the last is the 16-hydroxy metabolites. These metabolites tend to be more proliferative. So we see these elevated in patients with things like fibroids, or people who get kind of that breast tenderness with estrogen therapies. Okay, so we really generally want to see if we can move metabolism more towards that 2-OH E1. And there's therapeutics that can help, nutritional recommendations and supplements that can help support detoxification along that 2 pathway. The next thing that you see here is these phase 2 estrogen metabolites. This is represented by the conversion of 2-OH E1 to 2-methoxy E1. So this is the addition of methylation as that detoxification step. COMT is really heavily involved. So if you have done genetic testing on patients and they have a SNP on COMT, this might be particularly relevant for them, but you might pick up methylation difficulties even if they don't have that SNP. You can see in this case, this patient is kind of in the low normal range for 2-OH-E1s, post-menopausal. Although this doesn't look like a post-menopausal female, their estrogens are high. But when methylation occurs, you can see that their methoxy to methoxy E1 is in that postmenopausal range. This is showing that methylation is actually kind of low. You can see that best represented on this fan here. And this data is represented well in research. There's studies now that actually look at ratios, ratios as a number. Here we are looking at this in a pie chart. We can kind of show you what the patient's percentages are here and what the expected or desired range would be. So you can compare it that way. But there's also published ranges or published ratios that you could reference again to see how close your patient is to normal. But why would you care about estrogen metabolism for your patient? Well, here's the thing. If this patient was going to go on therapy and you dumped more estrogens into the system through exogenous hormone replacement therapy, you might actually be setting them up for a little more challenges because they have a higher 4-OH. They're not a good methylator. They might not respond well to it, or you might be causing more harm. So for a patient like this one, which we see all the time, you might want to think about going through a process to get their bioelimination and metabolism optimized first, and then initiating therapy and keeping them on that metabolism support to really make sure that they're able to excrete and properly metabolize the additional estrogens that you're going to give to them. So benefits of Dutch with baseline assessment, you get a complete hormonal picture, including the impact of those active metabolites. You can identify whether support for metabolism is needed. And then you can also see other parameters. I didn't talk about this on this one. We're going to talk a little bit about it next week when I talk about HPA axis. But the Dutch test gives you a real comprehensive look at other things that might be impacting menopausal symptoms like inflammation, thyroid health, oxidative stress, and we will talk a lot more in depth about HPA axis dysfunction. So a lot of benefits there. So let's say you put your patient on therapy and now you're thinking about monitoring therapy. We believe there's benefits of hormone therapy. They go far beyond decreasing vasomotor symptoms. We talked about bone protection, cardiovascular protection. There's early data showing cognitive support. So it's really important to make sure you get the dose right. And individual biochemistry can affect hormone metabolism. Also, different doses of hormone therapy can impact patients in an individualized way. So most of our providers test their patients about 3 months after they initiate hormone therapy until they get the patient's dose right. So every 3 months until they feel like they're on a good dose. And then once that dosing is established, we would recommend testing your patient 1 to 2 times per year on an ongoing basis. Now let's get into the question that everyone asks, which is what is the best way to monitor? You have options with serum, with saliva, or with urine testing. This is a hotly contested question in our community. And I would just put out there that generally we trust what we're taught, even without reading research ourselves. I've talked to so many providers about this, and this was a situation that I was in. I was taught what to do by someone I trusted, and I never read the studies that they reference in their PowerPoint. I just assumed that they were properly interpreting and drawing the right conclusions. But and I don't know who each of you learned from, but this is an area where I would encourage you to review the research yourself. Okay. Dive in, look at the conclusions on the slides and see if that's actually what the study said. Because many that I see on slides in HRT misrepresent the outcomes of the papers that they're referencing. And it's likely an error where that teacher learned it from someone else and they pulled that information off of their slides without reading the paper themselves as well. You have to dive in this area because it's a little bit murky. I'll just say one more thing about this because I know people say, well, you sell urine testing. So of course you're going to promote urine testing. What you're going to see is that one, we don't promote it for everything. We think that there's testing for reproductive hormones that's best done in serum. And we will absolutely tell you when that is, both with different types of therapy along with different hormones. And the other piece is that we have the equipment, the materials, the methodology to do saliva testing, but we only use it for cortisol because the data shows that cortisol is most accurate in saliva. What we have seen in research over and over and over again is that salivary testing for reproductive hormones, especially on therapy, but even with just baseline testing, it's not reproducible. It's not trustworthy. Okay, we're going to talk a little bit more about that. So let's start with estrogen. We don't recommend serum for monitoring estrogen therapies, and that's due to the pharmacokinetics making it really difficult to see what the right time frame is to get a clinically meaningful measurement. This is, again, a reason why routine testing is not done. Saliva has poor accuracy for estrogen, both for baseline endogenous production and for on therapy. Dutch, or this dried urine testing, provides a peer-reviewed, validated approach to measurement and offers the additional benefit of monitoring metabolites as well. This was an interesting paper. It's called Not Within Spitting Distance. You can see here, this was published in 2023, early in the year. We were not affiliated. We don't know anyone in the US who was affiliated with this study. It was totally independent. And what it showed was that even with baseline testing, not on therapy, saliva measurements for hormone failed to predict even the phase of the menstrual cycle women were in. So everyone knows estrogen goes through a couple of changes during the menstrual cycle, the follicular and the luteal phase. Measuring even your own production, flipping a coin was better than using testing to determine which menstrual phase a woman was in. It was really poor. There were a couple of methods that showed better sensitivity, but those were ones that were really lab only that are not scalable to be commercially available, and they're not the ones that are utilized in the US commercially. This is just the representation of that study here. You can see in this figure that the salivary immunoassays really did not show good comparison to serum. And then similarly, this breaks it down to different salivary assays that were available. These are the ELISA methods represented on the left. But even when you look at LCMS, they get a little bit better. These ones are ones that are typically utilized in a research environment. But even still, they couldn't touch the specificity of serum in that case. You can also see this yourself, if you don't want to read that paper, by looking at labs' published reference ranges for estradiol. This is a really interesting thing to look at. Look at the test companies that are out there as you walk the floor of a conference. We really can all agree that cycling females and postmenopausal females, you should be able to distinguish estrogen levels, estradiol levels between those two groups. If the reference ranges overlap, what that tells you is that that test is not sensitive enough to tell you whether that patient is cycling or postmenopausal. That feels really not sensitive to me, right? Here's an example. This is what serum looks like. And even in serum, this is LCMS-MS. This is the type of method, if you're going to run serum, that you want to look for. It might be labeled high sensitivity. It is typically more expensive, but it's the more accurate method. But what you see here is that if you look at the reference ranges reported by the lab, this is Quest that I'm using as an example. It puts the luteal range as 48 to 440 and the postmenopausal range as 0 to 10. This is Quest Labs. This is what you want to see. There's a gap here. You can easily distinguish, between below 10 is postmenopausal, above 48 is luteal. Here are the salivary ranges. We've taken the labs off of here, but you can see that every single one of them has overlap. And look at some of these are humongous overlap. So if your patient's measurement is right here, how do you know if they're postmenopausal or still cycling? Or here, or here? There's so much overlap. This one's really the best, but even still, it can't distinguish postmenopausal from cycling females. Now, Dutch, you can see here, we really are able to clearly distinguish, and that's a matter of sensitivity of the testing. So you want to look for a lab that has a gap there. If you're seeing an overlap in range, that should be a red flag. Now at Dutch, we also validated our estrogen replacement monitoring data. We have several publications. The most recent was published in Menopause, really well-respected journal. And this actually looked at creams, gels, and patches for estrogen replacement. You can see those three here. The patches is kind of this most linear. This is the gels, and then the creams were slightly lower. So really, when we look at therapy, with monitoring with Dutch, we laid this over so you can see this is what we have listed as our postmenopausal range. This is what we have as our luteal range for females that are still cycling. And you can see that this is no therapy, low dose, mid dose, and high dose therapy, which is you can see what they are down here below, 0.5 milligrams or less for creams and gels, 0.025 to 0.0375 for patches. That would be the low range group, all represented here. And you can look at the other ranges. But what we see here is that these doses, which were shown to be effective in clinical outcome studies, end up putting women really between the postmenopausal and the luteal ranges. Some of the higher doses push up slightly into the luteal range. One, this makes sense clinically. And two, it suggests that maybe that in-between zone would be a good therapeutic target. We don't have published data on that, but just something to think about as you're looking at Dutch testing when you have a woman on therapy. You want to see her lift out of that postmenopausal range into that in-between zone, or maybe slightly into that luteal range. So why Dutch for estrogen replacement therapy? The results scale up linearly with dosing. This makes sense. This is exactly what we should see. The results also parallel clinical outcomes data. And lastly, we have peer-reviewed evidence, not just of the method, but of our actual lab, gone through peer review with the team at Menopause, which is very discerning. Okay, so this can be really useful for patches, gels, transdermal creams, and also vaginal application. And it's also, again, when you run Dutch testing, it's inclusive of estrogen metabolites. Now, we don't recommend, if you're using like an oral CEE, we do not recommend Dutch testing. And the reason for that is when you ingest orally an estrogen, it's going to go through first pass in the liver before it hits any tissues. And that first pass in the liver dumps a lot of metabolites into the urine, as it should. What we see is that on Dutch testing, you would pick up all of those metabolites, making the result really overrepresenting the amount of estrogen that's hitting the tissues. So oral, we would not recommend Dutch, but transdermal and vaginal applications are fantastic to monitor with Dutch. Let's talk about progesterone. Now, studies clearly show oral micronized progesterone should be used for patients that have a uterus that are on estrogen therapy. Also, there are some studies suggesting vaginal can be a suitable option, vaginal progesterone. And that we won't really be talking about the details of that today, but we've got a lot of other education on that. Now, oral micronized progesterone isn't well measured anywhere, saliva, serum, or urine. So we actually don't recommend testing progesterone to monitor. Just use the doses that have been published and shown to be clinically effective. The studies generally use 100 to 200 milligrams of oral micronized progesterone. Now, I mentioned before, urine metabolites can still give you an important piece of information about the impact of progesterone therapy. So you might want to be looking at metabolites, again, to look at their affinity for GABA receptors. But the actual monitoring of dosing, we don't recommend using Dutch for, or anything, really. I want to just caution you, some of you may have been taught that transdermal progesterone applications are sufficient for endometrial protection. We know that there are some labs that are teaching this. There's some big thought leaders out there who still teach this. This we think is really flawed and dangerous, okay? There's one study that's utilized to support this approach. It's the author's Leonetti. And you'll see this quoted in a lot of people's presentations, but larger studies that were better quality, a couple of them are Ren and Vashisht, failed to show efficacy and actually showed endometrial over endometrial growth with using topical progesterone or transdermal progesterone. These studies are often omitted from the discussion if you look at people who are recommending it. So we do not recommend transdermal progesterone for endometrial protection. I will just say progesterone is a great starting point for hormone therapy for perimenopausal women. You might use it for other reasons, but for endometrial protection, when you're trying to pair progesterone with estrogens for women with a uterus, it's a no-go. Okay, so monitoring overall, we do have this downloadable PDF guide that you're welcome to download here. Again, this just walks you through what we recommend for oral progesterone, estradiol patches, gels, creams, vaginal. You can see vaginal progesterone, we don't recommend, transdermal, and you can see our recommendations for serum and saliva here. Saliva isn't shown on this, but it is on the real piece that you can see as well. So what are some of the benefits of Dutch testing? It's non-invasive. It can be collected anywhere. It's a urine test or urine and saliva, and it measures both active hormone levels, both baseline and on therapy. You can look at and measure on therapy levels. It does not overrepresent hormone levels on transdermal therapies. We do see this a lot in saliva, where there's an overrepresentation of the tissue exposure of hormone, and then providers really underdose the hormone therapies pretty significantly to the point where you're not even coming close with that physiological dosing. You're not even coming close to what's been shown to be effective in clinical trials. Just something to caution yourself over. So take a look at that. Lastly, Dutch looks at a 24-hour collection. So it's a much better representation of actual exposure versus the fluctuation that you might see if you're looking at serum, for example, because of the pharmacodynamics of that most recent application. Lastly, urine is the only matrix that allows you to measure downstream metabolites. So you can get that whole picture. And that's something that I really find irreplaceable. One caveat of urine testing is there is a SNP called the UGT SNP, which actually results in your body being not good at glucuronidation. Testosterone needs to be glucuronidated in order to spill into the urine. So if you ever see testing come back on Dutch, whether it's monitoring or not, men or women, you might find that the testosterone level is very low, like really low. And you think, gosh, this must be a problem. What's going on with this patient? This is a good thing to check for, is a UGT SNP. Because it's really popular, particularly in Asian populations. And that makes urine not a great measuring tool for testosterone for those specific patients. One thing you could look at is on the page, on males, it's reported on the main page, but for females, you can look at the table version. There's another measure called epi-testosterone, which is produced in about the same amounts of testosterone. If epi-T looks normal and testosterone looks very low, that's an indicator of probably that UGT SNP happening. Okay, in our last minutes, I want to just go through that Dutch report and what you might be looking at. So again, this is that hormone page that you can see the metabolite. You can see progesterone in the upper right, those estrogens and estrogen detoxification down below, and then in white, the androgens to the left. I want to also just remind you to look for that gap. Okay, this is how we represent the ranges for hormones as this dial. So you'll see these two stars representing the upper and lower end of normal for a cycling female in the mid-luteal range. That's this green zone here. Lost my cursor. This green zone here. And then you'll see this purple post-menopausal range. You can see there's a clear gap here. Look for this on your labs. This range should never overlap. And not all labs can do this with their method. Not all labs can be sensitive enough to really distinguish. And this is because we use mass spec, which allows us to be very specific in those female estrogen and progesterone ranges. We're going to talk more next week about HPA axis, but this is another invaluable page to get another understanding of HPA axis function, but not just that, your patient's resilience, their metabolic rate, whether they might have inflammation or oxidative stress or mitochondrial dysfunction. We can learn so much from this page. So if your menopausal female has stress, anxiety, depression, those mood changes that we're talking about, maybe sleep disruption, or weight gain, these are all reasons why this additional page and this additional information can be really helpful. And then I like to share this last page of the report before you get into all of our comments. This is our organic acid page, and I consider this just like the bonus page. There's so much extra info in here. Now, organic acids can be measured in urine, and a lot of them are markers for things like nutritional markers. So we've added in here a lot of markers that are measurable in urine that are really relevant to your patient's hormone status. For example, B12 and B6 markers. Of course, we know that if B12 and B6 are low, that can cause hormone disruption, particularly in cycling females. We have ones like biotin on here. If your patient's experiencing hair loss and you're wondering if it's hormonal, we have the ability to add a marker for biotin to see if it could be nutritional. So this page is full of real valuable info. I love to look at the glutathione marker here, as well as at the bottom, this 8-OHDG or 8-hydroxydeoxyguanosine, a great marker for oxidative stress and DNA damage. There's also quinolinate, which is a marker for neuroinflammation, but also relevant for just chronic inflammation in general. And then if your patient's experiencing mood changes and stress, we have dopamine and norepinephrine, epinephrine metabolites in here as well. So this is kind of like your extra little pot of gold, cherry on top bonus. Okay, in the last few minutes, when should I test my patient? When you're cycling females, you want to test around day 19 to 21 of a typical 28-day cycle. 7 days before the period starts or 7 days after ovulation is ideal. Menopausal women and men, it doesn't really matter. There's no luteal phase, so they can test on any day. Same with men. Okay. If patients are on therapy, estrogen replacement therapy, menopausal hormone therapy, or just hormone replacement therapy, our kits provide really detailed guidelines around how to properly take the Dutch test while using different forms of therapy. If you have questions, you can always call customer service for help, or if you go under DutchTest.com under education, Dr. Saltiel has a lot of great videos around when to test, so that education pages are really a gold mine. So thank you guys so much. Hopefully you've learned a little bit about hormone testing in the menopausal female. Just to kind of leave you with a couple of things. These are all the different things that we test for on our panels that you get with the Dutch Complete and the Dutch Plus. And so there's just so many reasons to be using Dutch. Comprehensive report, you get a ton of clinical support and education. And then lastly, and I referenced this, we really are focused on peer-reviewed, validated research. We're published every year. We have a great research team, and that's actually a really fun part of my job. From clinical support and education, we do have same-day call-in service. You can submit a form online. Our doctors will call you back. We have a large team of really experienced doctors there. And then just finally to talk a little bit about some of our research, we have done more and more data. We're very focused on peer-reviewed publications. So we have a page, dutchtest.com/research, if you want to get a link to and read those papers. We pay for them to be all open access so that you can really see them. We also this year launched 2 new hormone educational opportunities. The first is an interpretive guide, which is a walkthrough of the test. You pick what type of patient you're working with, cycling female, postmenopausal female, or male, and then it goes section by section, walking you through how to interpret it. If you want to learn more about hormone testing and about just functional management of hormones, we also have about a 7 to 8 hour course on mastering functional hormone testing that's available in the provider portal. So thank you guys so much. I hope you enjoyed this, and I look forward to talking with you guys in the panel.
Hello, everyone. Thank you for joining us today. This is Nayan Patel, pharmacist at Central Drugs Compounding Pharmacy and the author of the book, The Glutathione Revolution. It's my pleasure to be here today on this course on talking about advancements in bioidentical hormone replacement therapy and prescribing of that. Today, what we can talk about is the pros and cons of different dosage forms, what's working, what's not working, how the hormones been excreted out of the systems, and some of the protocols that we have observed at the pharmacy for over 23 plus years while helping the physicians all over the United States. So we all know most of the dosage forms are pretty simple, from capsules to sublingual troches, pellets, transdermal gels and creams, injectables, patches, suppositories, intravaginal inserts, and so on and so forth. What we do want to know is, how are these products being made in the pharmacy? As a physician, I would probably want you to understand, when you prescribe some medications, is how are they actually been made in the pharmacy, and how is it affecting your patient's outcomes? When it comes to capsules, there are 2 types of capsules. One is a regular capsules, where it dumps all the hormones into the gut instantaneously, and then some they are bound with some methyl cellulose, and what it does, it becomes like a little bit of a gel-like component, where it slowly releases the hormones out of your the complex over 8 to 10 hours of the time. They have a huge first pass effects, and sometimes this first pass effect is what we are looking for, especially when it comes to some of the hormone metabolites. And if you're doing some of the testings, the Dutch testings, the serum testings, you can measure some of those metabolites to see if that's what is actually what's happening. And so some of those capsules are very useful for that purposes. Suppository forms can be either used rectally or vaginally. The only difference between those 2 forms is, for the rectal suppositories, we have to use a vegetable base to as fatty acid or fat to put all the hormones together. And so we typically just have most of the suppositories that are made now are used for either vaginally or rectally. A good way to introduce hormones, which is what we are looking for when it comes to how do we get endogenous hormones being released into the system. Sublingual drops, tablets, troches, very, very popular. There are pharmacies out there who are just making those tablets, and in theory, it sounds so easy that, hey, just put a tablet under your tongue, let it dissolve over some time, and hopefully you get all buccal membrane absorption. And it's supposed to be very, very easy to do that. But we're going to talk about some of the pros and cons to either one of those as well. IM injections, most of the injections are esterified hormones. And we do that too so that they can be dissolved in the oil system. Most of the sterile hormones are not able to be dissolved in the oils. And so we have to make an esters of these hormones to make into the IM injections. The good thing about the IM shots is it has a little bit of longer half-life, so it has a sustained effect into your body. So that's always a good thing if there's a patient compliance is an issue. Pellets is a minor surgical procedure introduced to pellets into the systems. Ideally, you want to last it for over 3 to 6 months. So that way, it's a very slow release of hormones. There are some pellets approved by FDA, which is a testosterone pellets in men. They have been approved by FDA. We don't have any approval for hormonal pellets for female for hormone replacement therapy at this point. Topical creams, transdermal creams, gels, these are the topics that we're going to discuss most of it, because this is where we need to understand how are these products being made for what hormones, and based on what are the ingredients in these components is going to determine how are the hormones going to get absorbed into your system. So when it comes to topical creams are basically it's an oil in water emulsion. We need the oil phase to somehow dissolve some of the steroid preparations, estradiol, progesterone, testosterone, pregnenolone, DHEA. Those have to be somewhat dissolved into the oil phase. That oil phase is also combined with the water phase to make it more. The texture on your skin is much better, because as much as we would like to apply hormones every single day, we want to be cosmetically very appealing as well. So that's what most of the hormones are made up. Then we have transdermal creams. These are creams that have been using an active transport system like DIM to be used to drive the medication through the skin barriers into the bloodstream. And some of these hormones needs that extra drive, and so which is what we want to do. Commercially, all medications, all hormonal topical preparations uses a driver like alcohol to drive the hormones through the skin barriers. So we want to make sure that that's possible to keep on doing it as well. Then, of course, the gels that we talked about, they use alcohol as the base of all gels. Not a bad thing. The only downside to heavy using all the alcohol is that you cannot use it mucosal membrane. So if you want to apply intravaginally or in the guise of the perineal area or the scrotum area, it can burn. And so it's not an ideal application spot to do that part. Other than the fact that it helps the penetration of the hormones into the system, helps us predict how fast we can get the results. There's some advantages to that as well. When it comes to the alcohol-based preparations, the gels can actually dry your skin out, and sometimes it's not very pleasant for most of my patients. So having a non-alcohol based gels might be a better option to avoid some of the side effects of when it comes to the delivering the hormones on a daily basis. So before you start considering hormones, studying on anybody on hormones, these are some of the things that I want to look at it as a pharmacist. Again, as I said, we analyze well over 1 million plus prescriptions in the in my lifetime, and I've seen what's working, what's not working. So our goal is to always be, hey, what are the treatments being effective for our patients or not? And so we know hormones are the messengers, and when there's a lot of white noise around it, the message doesn't get across. I was given an analogy is that, hey, if we have a lot of people in your house and we have a very cramped up house, for you to talk about to one another, you have to raise your voice a little bit louder so you can hear each other. And so when you have issues with digestive issues, gut issues, food sensitivities and food allergies, stressors that is affecting your adrenal glands, metabolic disorders. These are all the noise inside your body, inflammation, all this noise inside your body. The message from the hormones are not getting across the pituitary fast enough. So while considering treating the hormones, we want to make sure that the first thing we want to do is to fix the gut-brain axis, fix the HPA axis, deal with all the other noises into the system, so that way the hormones become more and more effective. And as a pharmacist, I see this all the time, that it's easy to dump hormones because we have been trained to do so, but it is not that easy to try to identify where the issues are, and see how we can make the hormones, even a low dose, very, very effective. The whole goal is to make hormone at any dose effective for our patients. This was a recent article out of JAMA, out of the JAMA journal. They're talking about by 2030, women in South Korea with life expectancy is going to be over 90 years of age. That means they're going to live a longer life in the post-menopausal era than in the menopause era, assuming they're going into the first cycles around about the age of 15 or 16 and going into menopause at the age of about 48 to 50. So that means they have either the same life in the premenopausal area or cycling or reproductive area, a reproductive lifestyle, as much as what they're going to spend in the postmenopausal area as well. So we got to get this thing right. We have to help our patients feel better. How do we get the hormones treatment correct is instrumental for us to help improve quality of life, vasomotor symptoms, genitourinary syndrome of menopause, and hormonal issues with osteoporosis, heart disease, mental health. We're talking about mental health is a big crisis today, and we want to make sure that the hormones are good, are used effectively in our patients, so that they can live a very fruitful or useful life in the postmenopausal era. So let's talk about endogenous versus exogenous hormones. As we all know, all the hormones are produced endogenously. So endogenous hormones are something that are readily absorbed, are dumped into the bloodstreams, produced, and it's ready to be used by our organs, transported all throughout the body. Exogenous hormones, on the contrary, are the hormones that are been administered either via medications or food or the body care, the creams, the cosmetics, all the stuff that we use are laced with some sort of estrogen-like components, environmental toxins, and things like that. So these are the exogenous forms of hormones that come into the body. And so there's a slight difference. Our goal is to, of course, mimic as much as possible to have an endogenous hormone response, because we know somehow that we will be getting away with a lot less hormones with the better outcomes and less side effects. So what we want to find out is which dosage forms, capsules, tablets, troches, that we all want to consider as whether the exogenous hormones. How do we get to a place where we get some delivery system that gives us the endogenous effect? And as we know, capsules, tablets, troches, even the troches are supposed to be sublingual. 80% of them would not be dissolved in the due time that's in the mouth, and you end up getting a huge first pass effect from these hormones. In order for you to figure out how to give the endogenous form of hormones, we have used topical creams to be applied to the anal labia, vaginal suppositories, rectal suppositories, things like that, that basically will will try and mimic as close to endogenous form of production, but nothing can we do or give can be exactly same as the endogenous production of hormones. Then the second thought is, do we give continuous form of hormones or do we give cyclic, right? And so when it comes to hormone protocols, there's all these different theories on how we give hormones. As much as we would love to give continuous form of hormones, but to reduce side effects, but our body doesn't produce hormones on a continuous manner. It's almost cyclic. And during the reproductive time of a woman's life, the hormones are basically, you have the estrogen levels rising for the first 14 to 21 days. Then you have, as post ovulation, you have the progesterone levels that's rising, and so we want to figure out, can we give cyclical hormones in the post-menopausal time of the life as well? And of course, there are doctors that have done that way as well, by giving cyclical form of hormones, and there are physicians that have prescribed continuous form of hormones. And as a pharmacy that we see in our practice, what does the patients like to do? The biggest issue we have in the pharmacy is compliance. Over 88% of the total population of the United States are not compliant with the medication. So just because it's prescribed the medication, that doesn't mean the patient is going to take it. And that becomes very critical for us to understand that, hey, what's ideal versus what are patients willing to do. So understanding that, we need to have buy-ins for a patient. So I have some of the things that people have done successfully and seems to be working. And so one is that instead of having cyclical form of hormones, what the doctors have done is they have given like every Sunday off of hormones. Is one day enough a week to basically reset the hormones, hopefully help liver excrete the hormones and the metabolites, and so then we are back back taking more hormones the next day. The other seems to be working is also giving a 3 to 5 days continuous days off at the end of the month. And so that way it gives about 3 to 5 days to get rid of all the metabolites from the system. And hopefully that should be enough to regenerate the body and become free of hormones, so that we can give them more exogenous hormones again. And so there's different ways of doing this part. There's no right or wrong answer. All I'm trying to say is that work with the patients. What are they willing to do? If they're not compliant with one form of another, what's the second choice? If they're not compliant with any one of them, is the injections the best options, even though they're not bioidentical? Maybe that's the option for these people because they're not going to be compliant anyways. Or is bioidentical pellets another option for them as well? As I said earlier, pellets will have a 3 to 6 months of continuous form of hormones coming out, delivered to the body. So maybe that's an option for patients that are actually not going to be compliant at all with this hormone therapies. So what's working, what's not working? This is where the rubber meets the road. This is what we see all the time in the pharmacy. And again, we are not married to any protocol. What we want to see is that what are patients willing to do, and what are the patients refilling the medications all the time? Because keep in mind, all those hormones are out-of-pocket expense to these patients, and they're not going to spend the money if it's not working for them. So what is working? Low-dose hormones. It seems to be working very well as long as all the other components are taking care of it. And at PLMI, I mean, everybody's teaching us how to look a body as a whole and helping us reduce gut inflammation, reduce toxicities, and how can we get our body ready to accept these hormones? How do we remove all the white noise out of the system so the message from the hormones get across loud and clear with a very low dose? Topical hormones apply to the inner labia. in women, and perineal area in men has the best absorption. It seems to be working very well, and we can get away with low dose of hormones as well. Separating hormones, I see prescriptions where I get a topical cream with everything into one: estrogen, progesterone, testosterone, pregnenolone, DHA into one. Again, it's too much for receptors to use as hormones. What we do see refills all the time are the patients that are actually taking all the hormones separated, like estrogen, progesterone, testosterone. Everything is in a separate uh, cream by itself, and they use at different times of the day. We do see a combination of estrogens and testosterone together. It's a very low dose of each, so that seems to be working very well. But other than that, the progesterone is always going to be separated. The pregnenolone DHA is also going to be separated. Patches, pellets, and injections are also very effective for patients that are not compliant. Patches seems to be estradiol only, so which is bioidentical. There are combination patches which are not bioidentical, so just be aware of that. But if you're just using the estradiol patches, they're bioidentical, so those are going to be giving a continuous form of estrogens in your body as well. Sometimes the pellets and the injections are actually dumping a lot more hormones in the first as soon as you insert them or inject them. And that's why if you insert a pellets, we want to see your blood levels or Dutch test or all these different testings that we in next 3 to 4 weeks, because what we'll see is what the peak is going to be like. So even though in theory it's going to be slowly releasing the hormones for the next 3 to 6 months, in reality it's dumping the hormones at a very high rate in the first 3 to 4 weeks, and then slowly coming down over the next 3 to 6 months. So that initial peak, the initial high of all hormones may not be advisable in a lot of patients. They have high risk of developing cancers or family history of cancers, that we were trying to avoid them to getting too much levels of testosterone to begin with. So anyways, also when you give too much of hormones in the first at a given point, there tend to be a lot of side effects as well. Can be minimized by giving them estrogen blockers or high-dose progesterones, or something to block the conversion from testosterone to estrogens, whatever that things are, whatever the medication is. All we're trying to do is we're trying to minimize the side effects. In turn, it'll be easier just to use the hormones in a low dose to begin with, so you can avoid some of the other medications that are prescribed for that purposes. Excuse me. Lately, what we are seeing a lot is anhydrous gels of this hormones getting very, very popular right now in place of using oil and water emulsions. Oil and water emulsions are a little bit are good. There's a drawback is that there only has 19% oil phase in there, which is going to be which is not going to be the ideal, because it cannot deliver a lot of different hormones. But still, it's not bad, and it gives a very good cosmetic feeling. So we have used this for over a couple of decades. But lately, the anhydrous gels are coming out really, really good for that one, because what it is doing is that they're using drivers, not exactly alcohol, but they are using carbamers and other types of alcohol that doesn't dry your skin out. And they're using that in lieu of water to drive the medication through your skin into your bloodstream. And so it's getting very popular. I would probably assume that in the next couple of years, we might be exclusively seeing anhydrous gels being used in hormones all the time. The downside to the anhydrous gel is a little bit thicker, and so we try not to put too much hormones inside. We reduce the concentration of the hormones, and it seems to be working fine. Again, if we remove all the noise out of the body, we can get away with using low dose hormones in any ways. We also use DMI as dimethyl isosorbide. It's been used very effectively to solubilize the hormones and help penetrate the steroid hormones. So this is something that we have been using in the pharmacy for at least a decade plus, and by doing so, we are able to get similar levels in your serum testings or Dutch testings uh, uh, by using low dose hormones as well. So having these types of components definitely helps us. Beta cyclodextrin has been used to enhance absorption of testosterone. It's used as to stabilizing or helping absorb the testosterone and deliver the testosterone into the body. And so beta cyclodextrins, the downside to that one, there is a limitation on how much you can use per day, but most of the hormones are using once a day anyways. There's a limit of 5 milligrams per kilograms per day dosages, which we will not come even close to that part. Plus, we're only using it once a day treatment for most of the hormones anyway, so we should be okay using that as well. Oral capsules for progesterone, it seems to be helping, not for the progesterone treatment, but for the metabolism of progesterones. It seems to be binding the GABA receptors, as helping with the anxiety, mood swings, sleep disturbances, and things like that. DHEA oral capsules gets converted to DHEA sulfate. DHEA sulfate is has a longer half-life, about 7 days. We typically measure DHEA sulfate in the blood anyways, because that has a longer half-life, and they're supposed to be in equilibrium in ideal conditions, of course. And so having the DHEA sulfate levels are probably going to be something that we want to watch out for. And if you do topical DHEA, it's great because it stays as DHEA. There's less first pass effects, so it's supposed to be ideal for that purposes, to stay as DHEA alone. Pregnenolone, when we use pregnenolone and DHEA as together, that seem to have a better synergistic effect. And so we want to make sure that we want to use this product for that purposes. But if we should be cautious, if you're a patient with fatty liver, elevated liver enzymes, or have gene mutations, compromised cytochrome P450 systems, or factor V latent patients, we should not be giving any form of oral hormones to these people at all. There's a new medication that's got approved by FDA, the testosterone under weight, has a 30-day half-life when we given this particular esters of testosterone in an injectable form. But again, we still have to monitor the liver enzymes, which is why topical is a preferred route always. Most birth control tablets are synthetic form of estradiol, is the ester form of estradiols, and carries a risk for strokes, DVT, due to the fact that they have a long half-life. Again, it's the time inside your body which is more critical for us to know than giving the hormones on a daily basis. Because if the half-life is short, then we can get away with giving daily hormones. But if the half-life is very long, and then we give daily hormones, it just multiplies the effect exponentially. So when we talk about the hormones, we always talk about the pyramid, and the pyramid starts from adrenals as the base of all the treatments. We fix the insulin, we fix the thyroid, and end up fixing the sex hormones. But if we only treat everybody with the sex hormones, we are missing the whole picture of dealing the adrenals, the diet, and the thyroid. So we always think about it as the thyroid is actually the accelerator pedal that we have in the car. So if you can push that accelerator pedal as hard as you want, guess what? If there's no gas in the tank, which is the cortisol, your car is not going to move. So understanding that the cortisol needs to come before thyroid is very critical, and yet we jump to conclusion and give thyroid replacement all the time without taking the proper cortisols and making sure they have enough cortisol. They make sure that there's enough gas in the tank. And so when it comes to treatment, this is what I like to see in all my patients. As a pharmacist, I don't see this all the time because we are only doing the last thing, which is the hormones. But what we do want to see is the physicians getting involved in lifestyle factors, nutrients, herbs, activating the phase 1, phase 2 detoxification pathways on those patients before we start the hormones. Because if we do all those things, we'll be getting away with a very low dose form of hormones, and we'll have better outcomes with less side effects. So when it comes to lifestyle support, stress management, avoidance of sugar, alcohols, and caffeine, frequent small meals to stabilize blood sugar. Of course, there's all kinds of theories of intermittent fasting and you only eat very small window during the daytime. Again, I'm not here to talk about any of those different modalities or different approaches for fasting or stabilizing blood sugars up, but whatever it do to stabilize sugar levels or insulin levels would be great. Gentle exercise, not too much. What we like to see is that how much your body can stay in hormesis, so to speak. Adequate sleep, techniques to reduce the stress. I mean, I like to get all the stuff done, and it's not if you do one is enough. I like for all my patients to do everything: exercise, meditations, yoga, sleep, deep breathing. It's like having deep breathing and yoga at the same time will be fantastic. So you can do two, 3 things at the same time, like walking with guided imagery and visualizations. Can be another thing, or music therapy with Tai Chi, hydrotherapy with breath, with deep breathings, aromatherapy. I mean, all I'm telling you is combine as many things as possible, reduce the stress down, hopefully rejuvenate the adrenal glands. And if you need some nutrients to adrenal for the adrenal glands, vitamin C, vitamin Bs, magnesiums. Stuff that we have seen work a lot as a prescription item is the chromium picolinate, 2.5 milligrams BID for about 3 to 6 months. It's a heavy metal, so please don't use too much. Excuse me, I'm so sorry. Glandular supports, adaptogens, glyceric acid, which is licorice root extracts, which is very similar to giving hydrocortisone. Phosphorus and help reduce the cortisol levels down. So we use phosphorus to help reduce the cortisol levels. Between 200 to 300 milligrams is more than sufficient, even though people have used over 600 milligrams per day as well. Adaptogens are great supplementations to help regulate your stressors as well. Active phase 1, phase 2 detoxification pathways. This is also another critical component for us to we want to make sure that the phase 1 detoxification, the cruciferous vegetables, Brussels sprouts, cauliflowers, all those things are in your diet to kick in the phase 1. And the phase 2 would be methylations, acetylations, glutathione conjugations, oxidation protections. All these are going to be critical to activate to help make sure that the hormones that you're taking are being metabolized and out of the system. Glutaril, which is a topical form of glutathione, activates both phase 1 and phase 2 detoxification. Glutathione is by far the best product that the body produces. And now there's a technology by Oral Wellness that can improve the glutathione levels and helps with the conjugations of active metabolites. Hormone supports for the adrenals, corticosteroids, of course, progesterones, pregnenolones. Of course, we all know about the progesterone and pregnenolone steal. I'm not sure if that's a true phenomenon or not, but it seems to be helping our adrenals support. DHEA, 5 to 15 milligrams in females, 25 to 50 milligrams in men is going to be more than sufficient. Adrenals and progesterones, progesterone, pregnenolone steal. Again, results in the PMS type symptoms. Estrogen dominance is the big issues, and progesterone supplementations are also benefits for the adrenal functions as well. If you want to enhance the excretion of the hormones, we have used DIMS, the indole 3-carbinol, CDG, TMG. I mean, we have all these acronyms, and so please use them as it may help you with helping the hormones become more effective. So in summary, I know we're talking to, we want to talk about how the hormones are going to be helping our mental health. And what we want to do is we want to help activate everything in the body to help reduce the noise from all the food sensitivities and the toxins in the body. And if we can do that, the hormones becomes very, very effective. Better proper nutrition support is going to be the key. We have so many choices in treating hormones. Individuality is going to be necessary to have the best outcomes. And having a pharmacist on your team to help decide the ideal dosage form, ideal base of the creams, gels, appropriate dose, will deliver bespoke treatment for all our patients. So I want to thank you for joining us today. Appreciate the time with you today, and we look forward to seeing you in the part 2 of the series.
Well, here we are at the portion of the program that I dearly love, and that's our opportunity for the experts to interact in kind of a free-flow dialogue about this very, very important topic, hormonal balance and mental health and how it relates to going through the perimenopause and menopausal periods in women. A really important clinical topic, and could not obviously have 3 better experts in that in our panel. You had an opportunity to hear in this first phase of a 2-part series their presentation, so we don't need to address that again. But I thought it would be useful for us to kind of jump into this discussion and maybe a broader perspective, kind of summarizing some of the things that will lead us into chapter 2 or session 2 of this 2-part series. So if I could, knowing we've got Dr. Sarah Gottfried, Dr. Jacqueline Smeaton, Dr. Nayan Patel, 3 extraordinary experts at our disposal here, maybe I should start with a conversation just on a general theme, which is something that has come up many times in discussions around menopause, perimenopause, and hormone balance. And that is the bioidentical hormone replacement therapy concept. And whether it has impact on metabolism beyond that of reproductive function, and how and why this particular approach has received the kind of controversy that it's had over the years, and why it doesn't become a standard of care in the management of women across all sorts of different age and condition-related specifics. So with that as kind of a general question, maybe, Sarah, I'll start with you. Why do you think bioidentical hormone replacement therapy has had some of the controversy around it, and do you think it's because we don't look at the broader range of its impacts on metabolism and neuroimmune function?
It's a great question, Jeff. I would say intuitively, it makes sense to me that we would want to replace the hormones that are missing. And somehow we got into this situation with Premarin and with conjugated equine estrogen and medroxyprogesterone acetate, where the pharmaceutical companies really drove first Premarin to be one of the most popular prescriptions in the United States. And it was part of this vast, uncontrolled medical experiment on American women. So given that, and this idea that perhaps bioidentical hormones are a better fit because they're structurally identical to the hormones that women have always made, when we look at this question that you've raised of metabolism, I think about a few things. I think first, I think about the effect of progesterone on the brain. And we know that the neurosteroid progesterone has its own benevolent effects on the female brain in terms of memory, in terms of its activity with soothing and reducing anxiety in the female brain. We also know that the brain metabolism, cerebral metabolism, starts to falter over the age of 40. And while we still have a gap in the literature to look at the effect of bioidentical hormones and whether it might close that gap, and I'm referring here to the research of Lisa Mosconi that I talked about in my presentations, I suspect that estradiol and progesterone may have a beneficial effect on the loss of cerebral metabolism that occurs in 80% of female brains over the age of 40. So that's one of the ways that I think of metabolism, and I think about, the root cause being the faltering mitochondria in the female brain after 40, and how women who experience symptoms of cerebral hypometabolism and then have it documented with a PET FDG scan, these are the women who also have the most symptoms, the most vasomotor symptoms, the most depression, the most anxiety. And then the third possibility that I would want to raise here in terms of metabolic effects of bioidentical hormones, and here we do have a little more evidence, but it's not the highest quality, that's with breast cancer. So we believe that if you look at, for instance, the Women's Health Initiative, the increased risk of breast cancer that was documented in the first 5 years of treatment with conjugated equine estrogen and medroxyprogesterone acetate, that was an effect of a progestin. So we know now that there's a lower risk of breast cancer in women that were treated with a conjugated equine estrogen. So the medroxyprogesterone acetate seems to be the problem. And then if we look at observational data, mostly from Europe, there's one study in particular from Finland looking at more than 400,000 women, where they found that natural progesterone, also known as progesterone, seems to have a more beneficial effect on the breast. So those are some of the metabolic questions that I have when it comes to bioidentical hormones. Of course, we need more research to really be able to understand if we can close that gap, the metabolic gap that women start to experience after 40 with bioidenticals, but there's definitely some evidence that suggests that we might be able to.
Thank you. That was a really, really great landscape help in understanding this complexity. So now let me jump over to you. Obviously, Dr. Gottfried was just mentioning mitochondrial effects, bioenergetics, and how that drives a lot of these processes in the brain, knowing that the brain represents a small percentage of our body weight, 3 to 4%, but consumes over 20% of our oxygen. It's a very aerobically hungry organ because of all the energetics that go on in neurological function. You are an expert in the glutathione connection. Can you see part of the story here being tied into the glutathione status?
Absolutely. And this is something that I have been working on currently right now, 2024. We started the research on how can we improve glutathione levels in your brain. And there's a researcher out of Pittsburgh University who has the scanner that can scan levels of glutathione in your brain without doing an invasive procedure of measuring glutathione levels. So for the very first time, we are able to measure glutathione levels in the brain. And you said exactly right. 20% of the oxygen is consumed by the brain has only been 2% of the organ, and requires a lot of oxidative stress reduction capabilities from our body. So glutathione plays a very important role in there. And we also see for the estrogen metabolites, even on the gonadal sides, that to reduce the estrogen metabolites, we need to activate phase 1 detoxification pathways. The cytochrome P450, the CYP1B1 is the exact system that we have to activate. That activation happens by glutathione to get rid of the estrogen metabolites. So it works on both ways, but the research is still out there, and hopefully by end of 2024, I may have better things to report to you as to what we see with the technology that we have already developed on glutathione to improve levels in the cerebrum, to see if that can have an impact in the future. So we're still out for the research at this point, but we are working on it as of right now.
Yeah, thank you. I recall going back to the work at the University of Nebraska on estrogen metabolism and looking at these these dimers that occur as a consequence of estrogen oxidation going into the 4-hydroxyquinone derivatives. These are the secondary metabolites that glutathione conjugation plays a very important role in detoxifying these oxidative derivatives of estrogen before they have the opportunity to interact one with the other and cause mischief in terms of toxic pairing of DNA and mutagenic injury. So it sounds to me like we've got a lot of the oxygen storm issue going on here, possibly in the perimenopause menopausal area as well, in which these the cyclical nature of estrogen metabolism changes with the state of the menopausal cycle. Jacqueline, let me jump over to you and talk a little bit about the assessment. So when we go into looking at a woman going through the perimenopausal period, knowing that her hormones are a little bit like the Andes Mountains, one moment they may be very, very high, and then the next moment they may be in the valley of the Incas, and so this rapid rate of change that occurs in estrogen levels. How does that pertain to how a doc is going to use assessment tools to assess hormonal status using the Dutch test?
Well, that's a really great point. And I think that's truly a hallmark of perimenopause. I think a lot of providers think perimenopause is the slow, gradual decline of estrogen from a cycling state to a postmenopausal state, but it really is much more like puberty. It's up, it's down. You have cycles that look like reproductive cycles. You have cycles that then are anovulatory. It's like, I heard one provider describe it as like the end of a ketchup bottle when you're squeezing it, and sometimes you get nothing, and other times you get a big splurt coming out of the ovaries. And I thought that was a really great visualization. But it can make testing really challenging because, especially when we use kind of our standard tools like serum, serum can be very accurate if you're using the right methodology. However, it's only a single time point. And what that means is you're only getting a look at a snapshot or a moment in time. And in natural hormone production, even in a cycling woman or in a man, it changes from hour to hour. So it can be very difficult to get an overall assessment when you're only looking at a single time point. So that's why we talk about using Dutch testing. When we use urine and you get a 4-point time spot, we've validated that against a 24-hour urine and against serum as well, which allows you to really easily get a look at kind of the area under the curve rather than just a single point in time, which better allows you to assess a woman's hormonal status, particularly when it comes to estrogens, both before you initiate therapy as well as monitoring once they're on therapy to really understand what's going on or how much estrogen exposure that patient's getting.
I think that's a really important clinical insight. That's really news to use, I think, for everyone to pay attention to, because I believe that this concept of circadian rhythms and the nature of the cyclical periodicity, or even the asynchronous periodicity, because it doesn't occur on regular time like a normal menstrual period, is really important news to use for clinicians. Sarah, from your experience, how does that track into the way you manage a woman, knowing this is one of the issues of concern?
Well, I think these wild fluctuations are driving the most symptomatic period in a woman's life. So it's such a good point that it makes testing more challenging, but it also reinforces the point that we have in functional medicine, which is we don't just look at the labs. We look at what the patient is telling us, especially with our focus on mental health. We know that levels of hormones don't necessarily correlate with the mental health outcomes that we measure. So if I've got a patient who's telling me a narrative of increased anxiety or more depressive symptoms in perimenopause, and then in some ways, regardless of the kind of result that I see with testing, I'm still going to treat her. And with the situation where I become a little more cautious is I think of perimenopause in a couple of phases. I think of the initial phase as being this period where your ovaries just don't produce as much progesterone as they once did. And then I think of the second half of perimenopause as that period of time where estrogen is in decline. And so the way that it affects me, to answer your question, Jeff, is that I typically start with progesterone as my initial treatment, especially if I've got a woman who's, say, 42, 44, or 46, she's having trouble sleeping, she's got more anxiety, she's noticing that her cycle is closer together. Maybe she's got spotting or flooding or, some sort of change to the volume of her menses. I'm typically going to start her on progesterone first and see how it goes. If there's more of a depressive component, I think the evidence then points us in the direction of regulating those wild fluctuations with estradiol and with the downstream metabolites with some sort of dose of estradiol. And I typically start with the patch because I think it provides bioidentical estradiol alongside a lot of stability in terms of dosing. So that's how I approach it. And then in menopause, I think the testing is simpler.
Definitely.
Jacqueline, did you have anything you wanted to add to that discussion?
I think you bring up a really interesting point, Sarah. And one thing that's quite interesting, if you look into the clinical literature, is that there's not necessarily target therapeutic ranges because women are so diverse. You tend to see these broad ranges. Like there's not a level of estradiol that you'd measure where all women have no hot flashes, right? And I think that's because we don't truly understand whether that's a result of the estradiol level or whether that's a result of change, like a amount of change between before and after with a fluctuation. It's obviously the system is more complex than, say, one like, I mean, I don't want to oversimplify it, but hypothyroidism, where below a certain threshold, most people are going to be symptomatic. It's not the same way with reproductive hormones. So I think it becomes, like you said, Dr. Gottfried, a little bit more nuanced when it comes to figuring out how to treat and why we have to listen so much to our patients, because there isn't a lab threshold. There's kind of target ranges that we know that women on therapy, that those therapies have been proven to have bone protection or hot flash resolution. There's a range of therapies, and then you can kind of see where that range falls within a lab, but it's not absolute. So I think it's something to certainly be considering when it comes to personalizing for your patients.
This is such a good point. And Jeff, I feel like I need to have an homage to you because you're the one who taught me about the network effect of these hormones and to be thinking not about estrogen and progesterone and testosterone in isolation, but the way that they crosstalk with so many other systems. So when I order a Dutch on a patient, for instance, I'm not just looking at estrogen and progesterone, especially in a post-menopausal or peri-menopausal woman. I'm looking at what's going on with the androgens. How is DHEA affecting the immune system? I'm looking at cortisol. I'm looking at cortisol awakening response because there's so much interdependence between these hormonal systems. And then the way the hormonal network talks to other systems, like the immune system, like the neurological system, like the psychological system. So, Jacqueline, I think your point is right on that yes, we want to measure these things and we don't necessarily have target levels, although there are some anecdotal cutoffs that we could discuss. We want to look at the total picture. And that's where I think there's a lot of value to doing this additional testing, to looking at the whole family of hormones that are contributing to the mental health of a woman after 40 and to put it in context. And of course, it's not just a matter of, oh, you're low in estrogen, you're low in progesterone, let's top you off. We want to be thinking about, what are the effects of these medications? What if the patient has an autoimmune disease? How is that going to impact the immune function? So I really appreciate that point, Jacqueline.
Yeah, and I'm glad you bring that up because I think this is also a time in life where a lot of chronic diseases or underlying chronic problems also surface, or, we start to see the first like symptomology of it, like chronic inflammation, metabolic dysfunction, and how all of those things can be, very complex when it comes to teasing out. It's not usually just a single etiology going on for a lot of these things when it comes to mental health.
It's the two of you just listening to is so fun for me because you're you're really doing jazz. You're really pulling a lot of experience, both from research that's been done over the years, but also your clinical observations and the feedback we get from just being present in this community and looking at things from a systems biology perspective. And for me, it just kind of gives me goosebumps to hear this conversation, because as Nayan was talking about glutathione and neurological function, it interconnects into hormones, which connects to metabolism, which connects to all this broad range of symptoms. This is the complexity that probably keeps some people from moving into functional medicine, because we like simple answers. But it leads to a better understanding. And if we can go to simplexity, if we can take these complex concepts and to wrestle them to the ground, so we have some personalized answers for that individual that hasn't been successful yet, that's the whole payoff for going through this complex process of cerebration. And and you were very, very kind, Sarah, to acknowledge me as part of your system of information gathering. But I want to give a little bit of homage also to Candace Burt and Bruce McEwen, because if we think about a little bit of the broader context of where all these things interconnect, like to the stress connection, because for years the HPA-T axis, the hypothalamus, pituitary, adrenal, thyroid axis, was completely divorced from the gonadal axis. It was like they didn't cross their communities. But now we recognize, particularly from Bruce McEwen's work, that over 700 publications in this whole area of I guess you'd call it neurometabolism, but endocrinological metabolism. You can put a lot of words together. We start to recognize how these things are interconnected, and how things that we might have considered as separate, isolated, disciplinary owners. So some people owned neuronal function, some people owned hormonal function, some people owned immune function. But now we recognize it's a joint ownership, and that we need to embed ourselves in the process of being part of the community, because it's not just one at a time. So I'd like to just kind of ask the three of you, from your perspective, and I know this is a broad, huge question, so I'm overreaching here, but maybe you can give me a soundbite or two. How do you feel that this concept, the HPA-T axis, plays into this? Why did this take so long for people to bring that into the discussion about perimenopause and menopausal symptoms and the connection to estrogen and progesterone?
Well, I have a lot to say about this. I feel like, well, first of all, I do appreciate Bruce McEwen and Candace Burt, but I learned from you first, Jeff. And those cassette tapes, I don't know, 4 decades ago or something like that. But, what I learned when I went through my training at Institute for Functional Medicine is that the control system is the hypothalamic, pituitary, adrenal, thyroid, gonadal, gut axis. And I feel like that's the most accurate way to represent the network of what's controlling these downstream hormone levels that we're talking about testing. So even that, though, doesn't capture what's happening with innate immunity, what's happening with adaptive immunity, and how there are these dramatic changes that occur in a woman in perimenopause that lead to, as Jacqueline, you mentioned, the onset of chronic disease, especially autoimmune disease, vaccine effects, adverse vaccine effects. I saw most of them in my female patients that were in their 40s. And Nayan, as you mentioned, the oxidative stress dramatically increases for women in perimenopause and menopause. So we've got to be thinking about these networks of networks, and how you may have a woman that's sitting in your office with depression, but we want to be thinking about the role of the immune system. We want to be thinking certainly of the endocrine system and the metabolic system. Is cerebral hypometabolism part of the story? Is oxidative stress part of the story? So I think it's critical, especially as a bioengineer, that you're thinking about these control systems way beyond just the HPA-T.
So Nayan, let me jump over to you. That was I think Jacqueline and Sarah are laying out a brilliant architecture here for thinking about these issues that women go through in the different cycles from a broader perspective. So as you move over into the world of pharmacy and how a person who's expert in the art of using therapeutic agents actually engages in this system, how does that guide your thinking? How does that differentiate you as a pharmacist, pharmaceutical scientist from that of kind of traditional one-shot agent for one-shot symptom?
Well, the good thing for us is we have the privilege of seeing prescriptions from Dr. Gottfried and all the other doctors around the world prescribing medications, and we get to analyze all these prescriptions and see what's working, what's not working. So as a perspective, we can give you what's working, what's not working. As you can see during my presentation, I lay out all the plans, all my protocols as to what's working, what's not working. But all I can tell you is for all of you guys, Dr. Glenn, everybody, that please figure these things out, because we just heard that by 2030, the life expectancy for women in the world is going to be reached 90 years plus. That means they're going to live more than half the life in menopause than they lived in the reproductive cycle. So we got to figure this thing out regardless. And this topic is very important to me today, is because the number of health crises, especially with mental health crisis, that's increasing. And with the hormones, what I'm seeing is that we only dealing with reproductive cycles and we're not dealing with mental health. And now more and more physicians are prescribing medications for, we talk about depressions, anxiety, mood swings. But more than that, now we have brain fog issues. We have issues with suicidal ideations that's coming on. And so all these different things that I see on a daily basis at the pharmacy, and they're pleading to us and said, hey, can you make me some medications for that? And all I can tell them is that, hey, get the doctor to diagnose correctly. And it's not just the hormones, it's the full body approach is what we have to go at it. So my hands are tight. We can make medications. I need physicians to diagnose correctly, and we'll get to work. Rest assured, we will make the medication as long as we can diagnose correctly.
That's a beautiful. Please, I think someone wanted to jump in there. Please do.
Oh, I mean, I think you guys have laid it out so well. I mean, one of the things that was so fascinating to me, even in my undergrad, where I studied medical anthropology on top of biochem, was that when it comes to women's health, like most traditional cultures, like the Kung tribe, they experience cessation of menstrual cycles, but they don't experience the myriad of symptoms that are experienced in the Western world with perimenopause and menopause. And so, I mean, it's so fascinating to me because we think about all the ways that lifestyle is different, you know, a connection to nature, a connection to circadian rhythm, a traditional diet, a connection to family, living life with purpose and meaning. There's so many things that you can identify that are different that I think really truly impact a lot of these underlying physiological systems, certainly HPA axis function being one that you brought up, Jeff, that I think is heavily impacted. And when we think about what happens during perimenopause and menopause, you have a shift away from hormonal production from the ovaries to hormonal production by the adrenal glands. So it's really a time where those systems get ramped up and called upon in different ways. And so I think that some of those underlying pieces that are lifestyle related that impact that HPA-T system are really important to be thinking about from a preventive standpoint for younger women of reproductive age, and then even more importantly, as women approach perimenopause and menopause.
That's really beautifully stated. I've got one last kind of closing question. This could be, we could riff on this, I think, for a long time, but maybe I can just get your soundbite opinions in the last remaining minutes. And that is a term that's been used a lot about the hormonal imbalances that occur when stress is the mitigating factor or the amplifying factor. And that's the term pregnenolone steal. And, you know, goes back to this chicken wire diagram of biosynthesis of the hormones that go down through pregnenolone into the various secondary byproducts that are either stress hormones, glucocorticoids, or into the sex steroid hormones. So I'd like to get your thought or just your opinions about the concept of pregnenolone steal, whether that is a valid metaphor to be using, or is it misdirected? So, Jacqueline, maybe you can first give your thoughts about that.
I would vote on misdirected, very misdirected. I think the biggest piece to remember is that hormonal production happens at a cellular level. And so you have, within the adrenal glands, that production. I mean, for the cycling women, progesterone is made in the ovaries, cortisol is made in the adrenal glands. So pregnenolone doesn't transport to the adrenal glands magically to be converted into cortisol. It's distributed throughout the body. And so you wouldn't have, the ovaries not receiving enough because it's being converted more in the adrenal gland. So I think that the concept behind it, where when cortisol goes up, we see dysregulation in the reproductive tract, that's very well documented. However, the pregnenolone steal is not a scientifically viable explanation for why that's happening. That's my point of view.
Yep. Sarah, your thoughts?
I agree with Jacqueline. I would say no data, no data, no data. It's part of our mythology, I think, in integrative medicine. And yet, when you actually look at the science that it's based on, it's weak at best. And I feel like, yeah, Jacqueline, you mentioned, I think the way you described it is totally appropriate, which is we all see patients who've got dysregulation of this network. And so, the high cortisol folks, the low cortisol folks, the people that have high and low cortisol within the same day. And then when they're in more of a burnout phase and they're not making as much DHEA, yes, we all see that. But this idea that there's pregnenolone steal, I just don't think there's substantial evidence to support it.
Thank you. So now, just maybe you can be closing out on this. As a compounding pharmacist, do you have people wanting to compound products that combine pregnenolone with DHEA with downstream estrogen modulators?
So we do get compounded requests for pregnenolone DHEA all the time. And I completely agree with both the physicians that pregnenolone steal is a misnomer. Even though we use pregnenolone in high stress environment, but it's not to feed cortisol, it's to basically is to alleviate the symptoms of high stress. And so the pregnenolone steal or the progesterone steal terminology is misguided as at best. But we do get requests all the time. And when we combine them together, the pregnenolone and DHEA, they seem to have a synergistic effect. So we can get away with lower dosages to have a better outcomes or better Dutch test or better serum test.
Well, thank you. I want to thank the three of you. Obviously, we could continue this discussion on for a long time, and I would love it. But I think for the sake of staying with our timing, we'll have another shot at this at the end of part 2 of this series. So that's good for me that we could come back and revisit some of these questions. But I want to thank the three of you. This is a tremendously valuable 2-part series. And I think we've laid good groundwork here in part 1. So let's thank our listeners very much. And I thank you three. And we will revisit you all here at the end of part 2. And I'll wish you well.